Okay, let us now proceed to a session 4. The next two sessions will be the regional data presentation from all over Pakistan. And this session will be chaired by Professor Dr. Wase. Our co-chairs, Dr. Zakir Jan, consultant neurologist from Pakistan Institute of Medical Sciences. Dr. Danish Nabi, consultant neurologist from Hyatabad Medical Complex, Peshawar. So our first regional data presentation will be by Dr. Mohammad Bilal Waheed, who is a consultant neurologist at Allied Hospital, Faisalabad.
अस्सलाम वालेकुम जी। जो रीजनल डाटा प्रेजेंटेशन है वो उसकी हमारे पास स्लाइड्स बहुत कम है, बस आई एम हेयर टू प्रेजेंट ए वेरी एटिपिकल केस ऑफ मल्टीपल स्क्लेरोसिस. So we will start with the case presentation. A young male presented to us with the timeline of events. Back in 2023, he had his first neurological event. He had sudden onset of the left side vision loss, and it was extremely painful. Treated by pulse therapy by a local medical specialist. He was from Multan. He had partial recovery at that time, and MRI was done at that time, and it showed there you can see on MRI symmetrical periventricular and the subcortical white matter hyperintensities were found, not typical of multiple sclerosis. This is a typical tigroid appearance with no comments on the optic nerve in the previous record as per report. And on T2 flare, there was a raised suspicion for leukodystrophy. So the tigroid appearance is a typical appearance that you see in leukodystrophies. This is the guy. You can see there he's having facial myoclonias on the right side and might have a facial spasm as well. This is his second presentation, and we will be discussing the sequence of events in the second event he had. In January 2025, he presented to us with sudden onset of the right-sided vision loss, walking difficulty in the form of unsteady gait and severe imbalance. He was unable to stand and he was swaying on the right side. Typically, the features were on the right side. Along with this, he had facial myoclonias as shown in the video, urinary incontinence, and spastic paraplegia as well. Spastic paraplegia with the hypertonia and upgoing planters were there. He had impaired finger nose test on the right side as well. So we have 4 to 5 important findings only on the right side. His visual acuity was decreased on the right, and patient was having RAPD on the right side as well. Thorough neurological examination was performed. Ocular assessment, he had RAPD, visual acuity was decreased, and facial myoclonias. On the motor and coordination examination, we had impaired finger nose test on the right side, spastic paraplegia without any sensory impairment, and upgoing planters and hypertonia. Due to the spastic paraplegia, patient was having urinary incontinence as well. So a comprehensive workup was done parallel to his initial workup. As we do order the MRI cervical spine, brain, and orbit with contrast to assess the demyelination in space and time. We had a CSF analysis that wasn't done before, and for oligoclonal bands and cytology. His visual evoked potentials were done as well. We had his fundus photograph, and antibody testing was sent as well to rule out the underlying cause in case if he's having vasculitis or NMOSD. MRI brain and spine was performed, and you will see next there are quite significant lesions prevalent in the right cerebellum and the medulla. Persistent symmetrical periventricular white matter lesions were there as previously done in 2023. Patient was having a hyperintense T2 hyperintensity in the cervical spinal cord as well. His visual evoked potentials were performed. They were quite significant for optic atrophy. CSF analysis showed positive leucoclonal bands in the CSF and they were absent in serum. Fundus photograph showed optic atrophy and all the antibody panel was negative. So this is an MRI. You can see a new lesion here in the cerebellum and a lesion over here. T2 weighted axial view. You can see the demyelinating lesions, one there and this one is here on the right side. This is the cervical spine image of the MRI, T2 weighted. You can see a lesion spotted by the red spot on the cervical spine at the C6 level. Visual work potentials were performed and they showed a slowing of the P100 latency from 100 to 123 milliseconds. The bands were positive. This is the fundus picture showing optic atrophy. So the key findings that led us to the diagnosis of multiple sclerosis with atypical initial presentation back in 2023 were the new lesions in the right cerebellum and the medulla, presence of symmetrical periventricular lesions that were present initially, hyperintense signal lesion in the cervical spine, and no optic nerve enhancement was seen on the MRI. CSF was positive for bands, visual evoked potentials were positive, and serology was all negative. There was no antibodies and no vasculitis on workup was present. So we confirmed the multiple sclerosis having by applying the modified McDonald's criteria. Clinically, he had two distinct attacks. Optic nerve, the vision loss was there, and three different regions: cerebellum, medulla, and the cervical spinal cord. MRI dissemination was there, lesion in cerebellum, medulla, spinal cord, and optic pathways, confirming the dissemination in space. In objective evidence, we had CSF positive bands and delayed P100 latencies. Sporting features were patient had facial mychemias and optic disc atrophy. So this all advanced investigations led us to the diagnosis of multiple sclerosis that was initially diagnosed as leukodystrophy. So this slide is very much important. Key distinction that makes this atypical MRI and feature of multiple sclerosis: intact cognition, episodic history, documented demyelination on the visual evoked potentials, and positive bands. They helped us to rule out leukodystrophy. While some of the MS variants, as Marburg variant or diffuse sclerotic, do not have this kind of presentation on MRI. So this atypical MRI presentation contributed to the delay in initial MS diagnosis and the subsequent workup initially back in 2023. So late August में उसको एक और event होता है, उसको right arm की weakness होती है, and he had right-sided facial weakness as well. We did an MRI and you will see in the next slide there's a lesion in the left internal capsule, a new lesion. After 5 days of the treatment, he was quite well. There was marked improvement in the gait and his power was better. Here you can see the lesion in the posterior limb of the internal capsule. He did respond to good, he showed a very good response to methylprednisolone that was given for 5 days, and that further confirmed the patient is having multiple sclerosis. Dramatic improvement was observed, and the patient began walking independently without any support, and his gaits were improved significantly as well, with the improvement in visual acuity as well. He was put on disease modifying therapy, especially ocrelizumab. As you already know, okay, it is a targeted CD20 positive B cells monoclonal antibody that is responsible to decrease the immune cell damage that contributes to the myelin damage in multiple sclerosis. 6 months of the initiation of ocrelizumab, फर्स्ट 2 डोजेज के बाद उसको काफी हद तक अटैक्स जो हैं वो उसकी फ्रिक्वेंसी कम हो गई एंड this highlights the importance of timely and effective disease modifying therapies in managing multiple sclerosis. So, the lesson we have learned in this atypical case is that MRI unusual findings होना, उसकी डिफ्रेंशिएशन और डीमाइलिनेशन के साथ न्यूरोलॉजिकल कंडीशंस को रूल आउट करना बहुत ज़रूरी है. पेशेंट इनिशियली ल्यूकोडिस्ट्रॉफी के साथ आए और उसको क्लिनिकली वो फिट नहीं होता लेकिन उसको इन्वेस्टिगेट ना किया जाए तो ये पेशेंट के साथ जाती होगी. Bharal, we will investigate every possible demyelinating event with MRI or clonal bands. If you have facility with the visual log potentials, you can go for it, and antibody testing as well. And if the patient is having recurrent attacks, we should go for ocrelizumab, and that has magical results. So this slide shows the 1 year data of the regional demyelinating diseases. We had 79 cases of total CNS demyelination. Out of those, 42 were diagnosed as multiple sclerosis. 28 were clinical isolate syndrome, 2 were with ADAM, and 7 were diagnosed with an NMOSD. Ocrevus in 1 year, we have given 35 patients over the past 1 year. 13 of them had their first dose, and 22 had their subsequent second doses. Infusions were reported with no significant side effects, and patient had dramatic improvements. Thank you so much. Any questions?
Thank you, Dr. Bilal. Our next presentation will be by Dr. Gulzar Qayyum from Lady Reading Hospital, Peshawar.
Assalamu alaikum. My name is Dr. Gulzar. I'm PGR Neurology LRH, working under the supervision of Dr. Aisha Zafar. This is the experience with MS and related diseases at LRH from 2nd February 2024 to 5th of November 2025. So, age and gender distribution of overall demyelinating diseases, there was 42 female patient and 28 male patient. एज रेंज इज 32 45 ईयर में 53% ऑफ द पेशेंट जो है वो हमारे पास 30 to 45 ईयर एज रेंज में थे. डिस्ट्रीब्यूशन ऑफ डिजीज की बात करें तो MS 59% पेशेंट में था, NMOSD 33% पेशेंट में, मोगेट 7% में, और ऑप्टिक न्यूराइटिस के जो एक केस था वो 1%. MS एंड एज एंड जेंडर डिस्ट्रीब्यूशन की अगर बात करें तो ये एक्स एक्सिस पे आपको एज रेंज मिल जाएगी, और जो वाई एक्सिस है उस पे आपको नंबर ऑफ पेशेंट्स मिल जाएंगे. सो मेल एंड फीमेल की अगर बात करें 59% ऑफ द पेशेंट वर फीमेल एंड 41% ऑफ द पेशेंट वर मेल पेशेंट. अगर एज की बात करें तो 30 to 39%, 39% जो है वो 30 to 39 ईयर ऑफ एज में फॉलो कर रहे थे, मतलब से 3rd and 4th डिकेड ऑफ लाइफ में इसकी. Description, total number of patients diagnosed with MS was 41, 24 were female and 17 were male. Mean age of onset was 33 years. Minimum age was 17 and maximum age was 53. क्लिनिकल प्रेजेंटेशन में जो प्रीडोमिनेंट सिम्टम्स है, विजुअल एंड सेंसरी सिम्टम्स, वो फीमेल में ज़्यादा थे एज़ कम्पेयर टू मोटर सिम्टम्स जो मेल में ज़्यादा थे. सेरिबेलर एंड ब्रेन स्टेम सिम्टम्स कुछ पेशेंट में थे, और ऑटोनॉमिक सिम्टम्स. प्रीडोमिनेंट सिम्टम्स के हिसाब से ये क्लासिफाई किया है. और क्लासिफिकेशन ऑफ MS तो उसमें सबसे ज़्यादा रिलैप्सिंग रिमेटिंग के केसेस थे 73%, फॉलोड बाय सेकेंडरी प्रोग्रेसिव एंड प्राइमरी प्रोग्रेसिव 7%, एंड 2 पेशेंट वर ऑफ टीम इफेक्टिव MS. न्यूरो इमेजिंग में स्पेसिफिक ब्रेन लीजन्स मेल और फीमेल में जो पेशेंट थे 18 फीमेल पेशेंट थी जिनमें स्पेसिफिक ब्रेन लीजन्स थी, 12 जो है मेल पेशेंट्स थे जिनमें थी. वो CB's पॉजिटिविटी जो है वो फीमेल में ज़्यादा थी एज़ कम्पेयर टू मेल. और 2 पेशेंट इस तरह के थे कि जिनमें 4 पेशेंट इस तरह के थे जिनमें CB's अफोर्डेबिलिटी की वजह से नहीं हो सके. NMOSD कि अगर हम बात करें एज एंड जेंडर डिस्ट्रीब्यूशन की बात करें तो उसमें हमारे पास ज़्यादा जो पेशेंट थे 15 to 35 to 50 ईयर्स ऑफ एज में लाई कर रहे थे, और ये फीमेल 12 पेशेंट थे और मेल 11 पेशेंट्स थे. 30 to 35% 17% पेशेंट थे. 35 to 50 जो एज रेंज ग्रुप था उसमें 39% पेशेंट्स थे. Total number of patients was 23, 12 were female and 11 were male patient. Mean age of onset was 31 years. Minimum age 8 and maximum age was 50 years. क्लिनिकल प्रेजेंटेशन में ऑप्टिक न्यूराइटिस और माइलाइटिस के साथ जो पेशेंट प्रेजेंट हुए थे उसमें फीमेल पेशेंट 7 पेशेंट्स थे, 5 मेल पेशेंट्स थे और ऑप्टिक न्यूराइटिस के साथ 2 पेशेंट्स, माइलाइटिस के साथ सिर्फ जो है वो 1 पेशेंट फीमेल थी और 2 मेल पेशेंट थे। माइलाइटिक एंड ऑटोनॉमिक सिम्टम्स में 2 इन ईच ग्रुप थे। विजुअल लॉस की अगर बात करें तो यूनिलेटरल विजुअल लॉस जो है वो हमारे पास फीमेल 6 पेशेंट में यूनिलेटरल विजुअल लॉस था और 3 पेशेंट्स मेल पेशेंट में यूनिलेटरल विजुअल लॉस था। बायलेटरल जो है वो फीमेल में 2 पेशेंट्स थे और मेल में 1 पेशेंट। एक्वापोरिन स्टेटस पॉजिटिविटी जो है वो हमारे पास अगेन फीमेल में 7 पेशेंट्स में पॉजिटिव थे और मेल में 6 पेशेंट्स में, और 4 पेशेंट ईच नेगेटिव था और 2 पेशेंट्स ऐसे थे जिनमें उसी बीज नहीं हुए। इमेजिंग में सर्वाइकल डॉर्सल स्पाइन जो है वो सबसे ज़्यादा इन्वॉल्व था फीमेल में, और डॉर्सल स्पाइन की इन्वॉल्वमेंट मेल पेशेंट्स में ज़्यादा थी। मोगेट के 5 पेशेंट्स थे, 5 वो फीमेल पेशेंट्स थी हमारी, और 12 ईयर्स जो है वो एक पेशेंट की एज थी और 36 ईयर जो है वो एक तो यंग एज की। क्लिनिकल प्रेजेंटेशन में ऑप्टिक न्यूराइटिस प्लस माइलाइटिस और यूनिलेटरल विजुअल सिम्टम्स। मोगेट में ज़्यादा जो पेशेंट्स थे 5 में से 3 पेशेंट ऑप्टिक न्यूराइटिस के साथ प्रेजेंट हुए थे, 2 पेशेंट्स ऐसे थे जिनमें ऑप्टिक न्यूराइटिस प्लस माइलाइटिस के और यूनिलेटरल विजुअल लॉस 5 पेशेंट्स में देखा गया। इसमें सर्वाइको डॉर्सल स्पाइन और डॉर्सल स्पाइन इन्वॉल्व था जिनका माइलाइटिस था उसमें, और बाकी 3 पेशेंट जो ऑप्टिक न्यूराइटिस के साथ थे उनमें इमेजिंग नॉर्मल थी। First line treatment for every demyelinating disease was pulse therapy for 5 days, followed by plasmapheresis, azathioprine, and tapering steroid. In case of MS, second line therapy was ocrelizumab, and in case of NMSD and Mogate, we used rituximab. One patient with Mogate was treated on tocilizumab. 2 doses इनको मिली थी 1 month apart 8 mg per kg, but recurrence of attack की वजह से फिर इनको हमने rituximab पे शिफ्ट किया। फॉलो अप एंड साइड इफेक्ट ऑफ द ट्रीटमेंट। रिपीट इमेजिंग जो है वो हम 3 पेशेंट्स में की, 1 विद MS, 2 विद NMSD। NMSD पेशेंट्स को इम्प्रूवमेंट इन द प्रीवियस लीजन जो थी उनकी वो बिल्कुल नहीं थी, लेकिन ये एक पेशेंट में 10 ईयर्स के बाद हुई थी। 2016 में उनको LATM था और उसके बाद हमने 2024 में तो इसको हम रिपीट किया और रेटक्सीमेब पे थे ये। NMS patient shrinkage of the previous lesion was noted on brain imaging. She was on ocrelizumab, received 3 doses, performed 2 years later after initial presentation. Side effects में malaise and mild muscular pain was noted in 10 patients who received ocrelizumab and rituximab usually after the first dose. Weight gain and diarrhea was also noted in 7 patients. We manage a patient with biopsy proven demyelination. The biopsy was performed due to initial concern for CNS lymphoma. Patient presented with high-grade fever and signs of encephalopathy. He received 1 dose of rituximab, after which his clinical condition deteriorated. CSF PCR was subsequently performed and was positive for JC virus, likely trigger unmasked by the immunosuppressive effect of rituximab. ये पेशेंट बेसिकली बायोलेटरल विजुअल लॉस के साथ प्रेजेंट हुए थे। इनको पल्स किया गया, फिर इनको प्लाज्मा एक्सचेंज हुआ, लेकिन इसको कोई इम्प्रूवमेंट नहीं मिली, और इनकी जो उस वक्त MR थी उस पे इनकी डेफिनेटिव लीजन नहीं थी MS या डीमेलिनेशन की, लेकिन रिपीट इमेजिंग पे इनकी जो है वो लीजन्स थी, और टीम इफेक्टिव बाद में इनको फिर लेबल किया, और उसके साथ ये पेशेंट फिर हाई ग्रेड फीवर और एंसेफेलोपैथी के साथ हमारे पास प्रेजेंट हुए थे। रिटक्सीमेब की इनको 1 डोज मिली थी, तो वो मोस्ट प्रोबेबली हमें ये लग रहा था कि शायद रिटक्सीमेब की वजह से जो है वो JC वायरस एक्टिवेशन हुई। थैंक यू वेरी मच।
Next presentation will be by Dr. Israruddin from Liaquat University of Medical Health Sciences, Jamshoro.
यार अभी नहीं हो सकता, एक साथ ही करेंगे यार।
नजर आ रहा अपना
सेव नहीं किया थैंक यू change case services.
yes.
Assalamu alaikum to everyone. I'm Dr. Israr, working as a consultant neurologist, Liaquat University of Medical Health Science, Hyderabad. I'm highly thankful to the organizing committee and my supervisor, Professor Dr. Manzoor Ali, my mentor, Dr. Muslim Ali Abdul Hafiz Bugyo, who providing me the opportunity to being here and share the data of my region, that is Hyderabad. So the burden of demyelinating disorder in our region is very high. And Liaquat University Hospital is the single most government sector hospital, tertiary care hospital, who providing the neurological services to the region of Hyderabad and its nearby regions, which are roughly population of around 10 million peoples. So this is a map of Hyderabad and its nearby region. We have collected the data of 26 patients. Although this number may become high because a lot of private sector hospitals like Israr University Hospital and Suleiman Roshan Hospital, Indus Medical College also providing the neurological services to the Hyderabad region. So this number is concerned with the Liaquat University Hospital or government sector hospital only. This is the basic demographic data of patients. We have reported 12 patients in age 15 to 25 years, 8 patients in 25 to 35 age group, 3 patients in each 35 to 45 and 45 to 55 years of age group. Gender, 4 patients are reported as male and 22 patients are reported as female. Basic education of patients, 6 patients are having a primary education, 10 patients have secondary, and 3 patients have graduation level of education, and 7 patients have no formal education. Occupation, 21 patients are unemployed, and 5 patients are employed, and mostly are belonging to the rural areas. So 85% of patients are female and 15% are male. We have reported the sixth number of patients as a relapsing remitting multiple sclerosis, 8 patients as NMOSD, and 3 patients as MOGAD, 2 patients as ADAM, and 3 patients as CIS, and 4 patients are others who cannot fulfill the criteria of these disorders. We kept on these patients follow and counsel for the further workup. So 6 patients are reported as relapsing remitting multiple sclerosis, 3 patients are reported as CIS. While in the NMO spectrum of disorders, 5 patients are seropositive, 1 patient is seronegative, and 2 patients are those who are highly clinically and radiologically suspected NMO. 3 patients are MOGAD positive. So we have a limited options of treatment in our setup. This is the summarized data of all the 26 patients. We have done the investigations like MRI, VPs. However, there is no any facility of antibodies workup in our setup. We have counseled the patient to travel for Karachi, and there is also limited option of treatment. We have given the pulse therapy to all the patients in acute relapses, while there is no any facility available for the disease modifying therapies like ocrelizumab or something else. So we have choose the alternate pathway like azathioprine. We have kept the patient on azathioprine, and out of 26 patients, we have reported 4 or 6 patients have a good benefit. They have at least 3 years of gap with the second relapse. However, there is no any further option for our for the treatment option. This is the whole summarized data. Thank you.
To Dr. Israr. The next presentation will be by Dr. Rashna from Dow University of Health Sciences, Karachi.
Yes. Before starting, I would like to thank you organizing team. I'm Dr. Rashna, resident of neurology from Dove University of Health Sciences, presenting the data on neuromyelitis optica spectrum disorder that is beyond the traditional expectations. As neuromyelitis optica is a chronic relapsing remitting disorder that primarily affects the optic nerves and the spinal cord, it is associated with aquaporin 4 antibodies and may also involve the specific regions of brain. According to IPND 15 criteria, it contains the core features that are more common: optic neuritis, myelitis, area posterior syndrome, and the less common brainstem syndrome, acute diencephalic or narcolepsy, or Sidra syndrome. In our presentation, I used the term non-opticospinal manifestation that includes these all. And this is the IPND 15 criteria on which our study is based on. It is an observational study that is conducted in Department of Neurology in Civil Hospital, Karachi from January 2025 to September 2025. 65 patients diagnosed with NMOSD were enrolled, age more than 18 years, and the confirmed NMOSD patient according to IPND criteria. In this, newly diagnosed, relapse, remission, and the follow-up patient all were enrolled in this. On incomplete medical records, alternative diagnosis or mimickers were excluded with relevant history, examination, and investigation. Mean age was 31 years, in which the female was predominant, 72.3%, and the male was 27.7%. The literacy ratio is analyzed by national guidelines. 52.3% were uneducated, while 47.7% were educated. Patient 55.4% reside from the urban area, while 44.6% from the rural areas. 47.7% patient with first attack, while 44.6% presented with relapse, while 7.7% were in remission. On serology testing, aquaporin 4 were positive for 93.8%, while 6.2% were seronegative. The patient presented with opticospinal manifestation for 50.8, that was number is 33, and opticospinal and non-opticospinal features for 49.2, that is number is 32. None of the patient presented with isolated non-opticospinal features. Opticospinal features, optic neuritis, 12.3% patient presented with optic neuritis, while 17%, 26.2% presented with transverse myelitis, while 60% presented with both optic neuritis and the transverse myelitis. And non-opticospinal features, area posterior is mostly involved, 40.6%, acute brainstem syndrome was 31.2%, acute cerebral syndrome was 25%, acute diencephalic syndrome was 3.13%. None of the patients presented with a symptomatic narcolepsy. Talking about the non-opticospinal symptoms, mostly patients presented with the area posterior syndrome. Nausea and vomiting was common, 34.4%. Intractable hiccups was 28.1%. In acute diencephalic syndrome, patient presented with hypothermia and the hypotension. In acute brainstem syndrome, mostly patient presented with the diplopia and the bulbar symptoms. And the acute cerebral syndrome, patient presented with the hemiparesis, that was 31%, and encephalopathy was 15%, and the seizures were 6.3%. We evaluated and reviewed all the scans of their patient. Mostly involved the longitudinal extensive myelitis. The number is 38 among the 65. Optic nerve involvement was found in 17, brain stem lesion in 9, cerebral lesion in 5, and area posterior lesion in 4. These are few scans that shows the involvement of midbrain, pons, medulla, and cerebellum, and the cervicomedullary junction. And there's opticospinal features that involve the optic nerve and longitudinal extensive myelitis. The treatment we offered, all of the patients received IV methylprednisolone, that was 65. Among 47 didn't respond to alone methylprednisolone, they received the plasmapheresis combined. On long-term maintenance therapy, azathioprine was used in 61 patients, while 4 were given the rituximab. 86.2% patient has the lapsing remitting course, while 9.2 have the progressive disease, and 3 patient, 4.6% has a fatal outcome. So in our study, about 60% of patients presented with a spinal cord and optic nerve involvement, and the spinal cord symptoms being more common. Less common features such as the brainstem and the cyber symptoms were also frequent. The early recognition of these atypical symptoms is important so that they are not overlooked and diagnosis is not delayed. The limitation of our study is small sample size, single-centered study, and cross-sectional design. The challenges we face is a lack of awareness in our primary care centers that patient is not timely diagnosed, and the non-optical spinal symptoms are mostly considered as a constitutional symptoms like nausea and vomiting are treated in the peripheries like GI symptoms. So low socioeconomic status of the patient, they are not affording that much treatment for scans, and that non-compliance to the medication, cost of FDA-approved drugs, and also the unavailability of FDA-approved drugs, limited hospital resources, limited access to a specific diagnostic workup. Future recommendations are multi-center studies should require to generalize the data and explore the genetic and environmental influences of NMOSD presentation in this population. The less common presentation can appear as an initial symptom and should be carefully evaluated to avoid the missed and delayed diagnosis. Thank you so much.
Thank you, Dr. Rashna. Our next presentation will be by Dr. Saman Habib from Mayo Hospital, Lahore.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Saman Habib, postgraduate resident neurology, and I'm presenting data from Mayo Hospital, KEMU Lahore, under kind supervision of Dr. Aisha Aslam, Associate Professor of Neurology, Mayo Hospital, Lahore. This is a brief introduction of legendary Mayo Hospital, which is one of the oldest and largest hospital of the country, serving the humanity since 1871. And it was completed in 1870, and it started patient care in 1871. This is our beautiful Mayo Hospital. So our Department of Neurology is a 40-bedded unit, and we provide these services. Neurophysiological clinic is available in our ward, and plasmapheresis services are available at bedside of the patients, and neurorehabilitation services are also provided at bedside of the patient. So we started keeping record and follow-up of the demyelinating disorders starting from November 1st, 2024 to November 30th, 2025. and a total of 63 confirmed cases were included, according to modified McDonald's criteria and according to antibody testing as well, including NMO antibody testing, MOG antibody testing, and aquaporin antibody testing. And neuroimaging was also included as it is part and parcel of modified McDonald's criteria. MRI brain and orbit with IV contrast and contrast imaging of respective neural axes was done in respective patients. So overall, out of confirmed cases, we had 28 cases of multiple sclerosis and 18 cases of longitudinally extensive transverse myelitis, 10 cases of NMOSD, 5 cases of ADAM, 1 case of MUGAT, and 1 of radiologically isolated syndrome. So this is the pie chart showing that total distribution of the patients. Multiple sclerosis patients, there were 12 male patients and 16 female patients. 24 out of these patients were of relapsing and remitting pattern of multiple sclerosis. 3 were of secondary progressive multiple sclerosis, and 1 was of primary progressive multiple sclerosis. Out of 11 NMOSD patient, 1 patient was of MUGAD and 10 were of NMO. Gender-wise distribution showed out of total 63 patients, almost equal gender-wise distribution was there with slight female predominance. 33 patients of demyelinating disorders were females and 30 patients were males. Multiple sclerosis, there were total 28 patients and female predominance was there with 16 patients and 12 were males. Out of NMOSD 11 patients, 7 were females and 4 were males, and there was also slight overall female predominance here as well. Regarding treatment data, limited options are available. There is lack of financial and social support, high cost of treatment, and delayed presentation, basically. So treatment options available are steroids, DMARDs, including azathioprine, mycophenolate, Moftel, beta interferons, ocrelizumab, and plasmapheresis services are also offered. 53 patients were offered corticosteroids and 30 patients were given plasmapheresis services. 12 were given azathioprine, 8 were given mycophenolate, Moftel, and 16 were given ocrelizumab. This is overall distribution of the patients on maintenance therapies. Plasmapheresis services were availed by 30 patients. MS patients इनमें से 12 थे, 6 were NMOSD, 2 were of ADAM, and 10 were of transverse myelitis. That's all. Thank you.
Thank you, Dr. Saman. Our next presentation will be by Dr. Zainab Mohammed from CDA Hospital, Islamabad.
Assalamu alaikum everyone. Sorry because of my ill health and upper respiratory tract infection, also having cough as well, so my voice is a little changed. I hope this goes on well, smoothly. Let's get started. Bismillah Rahman Rahim. I am Dr. Zainab Mohammed. Bismillahirrahmanirrahim. I am Dr. Zainab Mohammed, a medical officer from Neurology CDA Hospital. And today I am going to share with you the experience of the CDA Hospital we encountered of demyelinating diseases. Our diagnostic criteria was that patient presented during from the duration of 17th of January 2024 to 5th December 2025. The formal data collection was prospective. Our inclusion criteria was the patient already diagnosed or suspected cases of CNS demyelination. Diseases are suspected are having CNS demyelination event upon first presentation or initial presentation. Patients presented to neurology unit inpatient or outdoor, and both genders of more than 12 years of age were included. Our suspected total cases of CNS demyelination were 22. Confirmed multiple sclerosis were 4. Confirmed NMOSD were 4. Optic neuritis was 1. Adam was 1, and Moged were 2 patients. The other patients, which initially were suspected CNS demyelination but turned out to be another cause, were 2 patients of lupus cerebritis. Intramedullary spinal tumors were 4 patients. LETM with Sjogren syndrome was 1. LETM associated with hepatitis E infection was 1, and 2 patients of clinically isolated syndromes. This chart is showing the female predominance of multiple sclerosis patients. With predominantly, we encountered relapsing remitting MS at our hospital. No patients of secondary progressive or primary progressive MS were encountered yet. 4 cases of NMOSD, all were antibody positive with the female predominance, and 2 patients of MOGAD with male predominance. Treatment options, as you all know, we give at the in practice in Pakistan are approved options, off-label option, and other medications. The approved options were beta interferon, teriflunomide, ocrelizumab, alemtuzumab, mitoxantrone. There are some off-label options as well. Most commonly used is rituximab or monthly prednisolone, azathioprine, and rest of the options as well. The treatment given to the CD hospital patient was 3 patients of relapsing remitting MS are on ocrelizumab, 3 patients of NMOSD are on rituximab, and 1 patient of our relapsing remitting MS is on rituximab. 2 patients of MOGAD are on rituximab, and one patient of LETM with Sjogren is on cyclophosphamide, and 1 patient of NMOSD is on azathioprine because of the patient preference and affordability issues. Thank you, everyone, for giving me opportunity to present.
Our next presentation will be by Dr. Sidra Bibi from Hyatabad Medical Complex, Peshawar.
Assalamu alaikum. I'm Dr. Sidra, resident physician from Hyatabad Medical Complex, Peshawar. Today, I will present our regional data on NMOSD, MOGAD, and dual negative patients. These are my objectives. So we collected and analyzed 108 patients over the last 2.5 years who presented with symptoms suggestive of NMOSD, MOGAD, and other demyelinating disorders. This slide shows a spectrum of disease presentations we encountered. 14 patients were presented with isolated optic neuritis. 64 patients had isolated myelitis, and 27 patients presented with optic neuritis along with myelitis, while 10 patients presented with myelitis and area postrema syndrome. Out of 108 patients, 59 had aquaporin 4 positivity, while 22 patients had anti-MOG positivity. The remaining 26 patients were dual negative. This slide shows antibody status in patients with isolated myelitis. So the 24 patients were aquaporin 4 positive, and 14 patients were anti-MOG positive, while 12 patients were dual negative. Patient who presented with isolated optic neuritis, the aquaporin 4 positivity was the predominant pattern, followed by anti-MOG. Patient who presented with optic neuritis along with myelitis, the aquaporin 4 positivity was predominant, followed by dual negative patients. 7 out of 10 patients presented with 7 out of 10 patients who presented with myelitis and area posterior syndrome were aquaporin 4 positive, followed by dual negative cases. This slide has already been discussed. Coming to the other clinical and demographic parameters, the age range between 10 and 60 years. Female patients were predominant, with 76 patients were female and 31 were males. In terms of autoimmune background, 16 patients were ANA positive, while 33 patients were ANA negative. Comorbidities include diabetes, hypertension, recent febrile illness, and rheumatoid arthritis. Virology status, ESR and CSF varied across the patients. However, CSF typically showed the lymphocytic predominant picture with maximum cells count of 296. Coming to the spinal cord involvement, 22 patients had cervical cord LETM, and again the aquaporin 4 was the predominant pattern, followed by dual negative cases. 27 patients had dorsal cord LATM, and the dual negative patients were predominant here. 33 patients had cervicodorsal LATM, and the aquaporin 4 positivity was again predominant. Regarding the treatment response, all of our patients received IV methylprednisolone, and most of the patients received plasmapheresis. Our 9 patients received cyclophosphamide, and their EDSS score ranged widely. 3 patients had EDSS below 6, 2 patients had EDSS between 6 and 8, while 4 patients had EDSS above 8. Among the 42 patients who received rituximab, the EDSS, 5 patients had EDSS below 6, 12 patients had EDSS between 6 and 8, while 8 patients had EDSS above 8. A number of patients were unfortunately lost to follow-up. In our optic neuritis subgroup of patient, one patient vision improved to 6/12. 2 patient vision improved from hand movements to counting fingers, and 2 patients vision improved from hand movements from no perception of light to perception of light, and from hand movements to counting fingers, while 1 patient did not show a significant improvement. To conclude, females were predominant than males. The most patient presented between age 20 and 40 years. Myelitis was the frequent presenting symptom. Aquaporin 4 was most predominant than anti-MOG, followed by seronegative. Aquaporin 4 was strongly associated with isolated myelitis cases. Anti-MOG were associated with the isolated optic neuritis patients. All isolated optic neuritis patients were seropositive. ENA, ESR, and CSF varied across the patient. The cervicodorsal cord involvement was the most common MRI feature. Relapses were high and were highly disabling. Dual negative patients required further research. We also encountered major affordability issues and lack of timely referrals. Thank you.
Thank you, Dr. Sidra. Our next presenter is Dr. Maryam Jabeen from Polyclinic Hospital, Islamabad.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I am Dr. Maryam Jabeen. I am a classified medical specialist and a resident neurology at Federal Government Polyclinic Hospital, Islamabad. Today, I'm going to present the data of the demyelinating diseases that are enrolled in the Federal Government Polyclinic Hospital. So we had in the previous 5 years, we have already presented the data of our patients during the time period of 2019 to 2024. We had a total of 30 cases at that time. This year, from January 2025 up till now, we have enrolled total of new cases, 15 new cases. Of them, 4 were males and 11 were females. And of them, most of them were having their first presentation in the age group of 20 to 30 years. And most of them patients who were following the remitting and relapsing pattern of the MS, and one with the primary progressive MS and one with the secondary progressive MS, and 2 other, one of them was the MOGAD. So most of them have their first presentation as cerebellar sensory odomotor symptoms. 5 were having their first presentation as optic neuritis, and 1 with the trigeminal neuralgia. So a quick review of the data of these patients. You can see here as that most of the patients were following the remitting and relapsing pattern of the MS, and they were having 2 to 3 relapses respectively. And we have given all of these patients ocrelizumab as the disease-modifying therapy. Here again, all of these patients were following the remitting and relapsing pattern of the MS. If you can see here is a patient, 30 years old patient. She was following the secondary progressive type of MS, and she was also having the coexistent epilepsy, and she was having depressive illness as well. Another 45 years old male who was having progressively increasing weakness of all the 4 limbs for last 13 months, and he was labeled as primary progressive MS. Another patient, 28 years old lady who presented to us with the transverse myelitis. Neuroimaging showed the longitudinally extensive transverse myelitis, and there was positive OCBs, and anti-MOG antibodies were positive, anti-aquaporin antibodies were negative. So for patient is only given with the methylprednisolone, and she responded to the treatment well. Another patient, we have 29 years old lady. She also presented to us with a partial transverse myelitis with the sensory level. She also had the prior history of the 2 miscarriages and did not conceive after that. And with the suspicion of demyelinating disease and possible APLAS, she is under the workup. I would like to discuss 2 of the interesting cases we have come across during this time period. One is the 44 years old lady. She was initially treated as trigeminal neuralgia. And initially she responded to the treatment, and at the time of diagnosis, neuroimaging was done, and that was unremarkable. But with the passage of the time, she was having progressively increasing in the intensity, and ultimately this was refractory to treatment. Up to 3 drugs, she did not respond to these drugs. So again, neuroimaging was planned. So if you can see here is here are the some hyperintense lesion on the FLAIR image. Here you can see here is here are some hyperintense lesions. But I want to just let you know, see these lesions. If you see, here is the area of the pons. And if you see, here is the area corresponding to the trigeminal nerve. And this was the hyperintense lesion that was probably irritating the trigeminal nerve for the manifestation as trigeminal neuralgia. So another lesion, if you can see here, is a lesion that shows the perivenular hyperintensity. As per radiologists, this can be the possibility of the central venous sign as per 2024 McDonald's criteria. So we treated this patient with the ocrelizumab along with the symptomatic treatment. So another case I would like to discuss this. This is the case of 30 years old lady. She was having the history of sudden loss of consciousness and also had fits during 2014. 2014, and she was treated as the case of epilepsy, and currently she was fits free and she was not taking any anti-epileptic drugs. During 2015, she was having certain left-sided weakness of the arm and the leg that was followed by right-sided weakness. That time, she was given with the solomodrol and she completely responded to the treatment. And up till now, you can see this was the MRI done at the time of 2015. There are obvious T2 and flare hyper-intense lesion that were there. These you can see here in the periventricular areas, and some of them are exactly perpendicular to the ventricles. Better appreciated on this coronal view. You can appreciate here the lesions that are exactly perpendicular to the ventricles. These were basically consistent with the demyelinating disease but at that time patient was not treated for the demyelinating disease. So she remained stable up to 2018. And in 2018, she was socially withdrawn due to her mother's death. And family also reported some difficulty in weakness, but she was just treated for the depressive illness. And in 2023, she was having progressive weakness and decreased mobility. And there was also difficulty in walking, and she became ataxic. And up till now, she's a wheelchair-bound person, and she was dependent on one person. And she visited to us during this time period of 2025. Again, this MRI was done that showed the enhancement of these basically increased size of these periventricular lesions. And again, you can see here is the age inappropriate atrophy of the brain. Basically, the main reason for discussion of this patient was that MS in certain cases can present as epilepsy when the plaques are in the cortical areas. So timely diagnosis and timely treatment may limit the disability. So during her encounter in our institution, we have started her with a demyelinating, disease-modifying therapy as ocrelizumab. That's all from my side. Thank you so much.
Thank you, Dr. Maryam. So I think that was a good tour of Pakistan, where the only souvenir we got were clinical insights. So this brings us to the end of this session. Now I would like to call Dr. Zakir and Dr. Danish Nabi for any comments on this session.
Bismillahirrahmanirrahim. First of all, I would like to congratulate all the members who arranged this Paktrims conference. Then also inviting different PGs and consultants from across Pakistan to participate and present their data. Collecting data on the part of TMOs, I think it's not an easy job, like doing the routine duties and then collecting the data of different patients and different disease. So all the presenters who work very hard with their presentations as well as the data collection. And I think as previously Dr. Maimuna said that the data that has been collected should be published as well. That will have a more impact of these conferences. Thank you. Thank you.
Thank you very much. Just a few observations. One of our presenters had names of the patients in his presentations being displayed, so I think that should not be there. There was another thing, cyclophosphamide, which is not used commonly in our setups, especially in PIMS. It was used more in patients by Dr. Sidra. So if we can have some input from her, why was that used almost 9 patients? Regarding the patient with trigeminal neuralgia, every young patient who has especially age less than 40 or around 40 must be investigated for a demyelinating disease before labeling her as a trigeminal neuralgia.
Dr. Sidra, are you there? Okay, can you please answer the question? Sir has a question that why was cyclophosphamide used in 9 of your patients?
सॉरी सर, बहुत सारे पेशेंट्स जो थे हमारे, उनको अफोर्डेबिलिटी इश्यूज थे। तो एक ऑप्शन ये था हमारे पास साइक्लोफॉस्फामाइड का, और उनकी एज ऐसे थी कि रिप्रोडक्टिव एज से ज़्यादा थी। तो फिर ऐसे पेशेंट्स में हमने ये एक ऑप्शन ऑप्ट किया था। Yes, 3 patients had EDSS below 6, and 12 patients, 2 patients had EDSS between 6 and 8.
सर इसमें
Thank
से
you.
आते पेशेंट्स रिलैप्सेस हो रहे थे डिस्पाइट ऑन एज़ाथाइप्रिन, तो वो रिटक्सिमाब को अफोर्ड नहीं कर पा रहे थे क्योंकि हमारे सेटअप में सेहत कार्ड पे रिटक्सिमाब अवेलेबल नहीं है फॉर एनएमओएसडी पेशेंट या। तो उन दोस्त को इस समय कह के फर्दर जाना है उधर देन रिटक्सिमाब मेरे पास ऑप्शन हो जो आधा ऑफ लेवल है। तो वी ट्राइड, कुछ पेशेंट को इम्प्रूवमेंट हुई कुछ को ना हुई, लेकिन एक पेशेंट जिसको डेफिनेटली इंप्रूव नहीं, वो डुअल नेगेटिव केस था जिसको फर्स्ट टाइम इनिशियली बहुत अच्छी इंप्रूवमेंट हुई थी रिटक्सिमाब, लेकिन लॉस टू फॉलो अप दवाई अक्सर हमारे पेशेंट छोड़ देते हैं, कंप्लायंस का इशू बहुत ज़्यादा होता है। तो फिर उसके बाद रिलैप्स में उसको हमने फिर सब ट्राई किया, सब कुछ इंप्रूवमेंट नहीं हुई, लेकिन पैक्लोफोसमाइड फॉर अ पेशेंट जो अफोर्ड नहीं कर सकता, एल्डरली पेशेंट हो या फीमेल हो जो एज में ना हो, तो एक ऑप्शन बंदा कंसिडर कर सकता है रिसोल्वेंट केस में। बैतुल माल में सर वो 1 ईयर से ज़्यादा वो टाइम बहुत ज़्यादा लेते हैं, क्योंकि अप्लाई अप्लाई कर देते हैं लेकिन वो टाइम लेते हैं, तो हम एटलीस्ट उससे पहले ट्रीटमेंट कुछ ना कुछ स्टार्ट कर देते हैं सर।
Okay, thank you. And this brings us to the end of the session 4. I would now like to call Dr. Mansoor Iqbal Chaudhary, Head of Neurology Department, Pakistan Institute of Medical Sciences, for the distribution of certificates. So we'll start with the presenters of this session. Dr. Gulzar Qayyum. Dr. Muhammad Bilal Waheed. Dr. Israr Uddin. Dr. Rashna. Dr. Saman Habib. Dr. Zainab Muhammad. Dr. Sidra Bibi. Dr. Maryam Jabeen. And now the certificates for our worthy co-chairs, Dr. Zakir Jan. And Dr. Danish Nabi. So we'll now have a 5-minute break, and then we will proceed with the next session, session number 5, and it will be started with a very informative presentation by Dr. Atika Paracha. She has joined us live from USA, and she will talk on the new McDonald criteria 2024.
I don't know, can you open it one more to be? यहाँ पे आना चाहिए ना, इसमें एक और आनी चाहिए, 2 स्लाइड आनी चाहिए। करो, नहीं आ रही। ये आई जा रहा है, इधर से पीछे जाना, यहाँ पे रख के क्लिक करो, ये इसको क्लिक करो, मैंने इसको इससे नहीं आ रहा, आ रहा है ना, ये तो देखो ना, यही प्रेजेंटेशन आ रहा है। अब ये इसका नेक्स्ट एक्सक्यूज मी, इसमें ना लास्ट स्लाइड में 2-3 क्लिक्स के ऊपर स्लाइड आती है, वो नहीं आ रही, वो कैसे आएगी?
ये तो आपने जो भेजा था वही है ये तो।
नहीं वो है ना,
ये उस वाली
ठीक है।
यही है, लेकिन अभी आपका नहीं है।
नहीं मुझे पता है, मैं वैसे चेक कर,
ये ऐसे प्रेजेंट करेंगे तो उसके ऊपर ये
प्रेजेंट
इनको
व्यू
नजर आएगा, ये इनको नजर आएगा जब ये प्रेजेंट करेंगे।
ये अभी जब करेगा तो उसको पता चलेगा।
फिर पता कर लेना, क्योंकि मैंने इसको बताया तो फिर
नहीं अभी वो करेक्ट हुई है ना वहाँ से, ये से कनेक्ट।
जी हेलो, मैं कनेक्टेड हूँ।
2 प्रेजेंटेशंस के बीच
लेकिन होल्ड तक आ जाएंगे।
मुझे प्रेजेंट व्यू लाजमी चाहिए
स्क्रीन पे।
एक मिनट, ये आप पे लाइट मीटिंग है।
उसके बाद पता चलेगा।
अभी
बाकी सब प्रेजेंट करते हैं, उनका प्रेजेंटर व्यू था, सिंपल प्रेजेंट करें,
सिंपल प्रेजेंट करेंगे, ये प्रेजेंटर भी बताओ कर देते हैं।
बस मैं यही पूछ रहा था।
हाँ क्या कौन सी एक मिनट नहीं आ गया नहीं खुल जाएगी तो कैसे हाँ आप दे रहे हैं
चाहिए लेकिन वहाँ नहीं चाहिए
क्यों
क्योंकि वो नहीं शो होना चाहिए ना प्रेजेंटर के लिए बताइए और ऑडियंस
ओए
ये प्रॉब्लम है समझ गए जैसे आगे आए ना
अभी जैसे क्या ना आप वैसे ही कर दीजिएगा मैं ओपन कर दूंगा आप जो करते हो
स्टार्ट करेंगे उसके बाद तुम्हें ऑल बायो वाला करके करना है इनको जूम में आ जाना कनेक्ट हो जाएगा
We will now proceed to our next session. Everybody is please requested to be seated. Our next session will be chaired by Professor Naila Shehbaz. And our co-chairs for this session would be Dr. Sadaf Nasir from Polyclinic Hospital and Dr. Zishan Munawar from Pakistan Institute of Medical Sciences. Okay, so our first talk for this session would be by Dr. Atika Paracha. She has joined us live from USA. Thank you very much, madam. Dr. Atika Paracha graduated from Dow University of Health Sciences, Karachi, and she is a certified from American Board of Psychiatry and Neurology. And she is currently working as a physician at Barnabas Health Multiple Sclerosis Comprehensive Care Center, Livingston, New Jersey. And she will talk about 2024 McDonald's criteria for multiple sclerosis.
Thank you. Can you guys hear me?
Yes, madam, we can hear you. Can you please share your presentation?
Yes, I can start my presentation here.
Okay, thank you.
Let me know if you can see it.
Yes, we can see it.
Okay, I'm going to put it in a slideshow format. And then start from. Can you see it properly? Or in the presenter mode? Okay. I'm going to start here. Assalamu alaikum, everyone. My name is Atika Paracha. I'm a board certified neurologist currently working in New Jersey. I did fellowship in MS and currently only see MS patients. I quickly wanted to talk about the McDonald's criteria that was updated last year, but as we all know, the paper was published in September 2025. So even though the name says 2024, it's technically 2025. As we all know, moving forward, just few basic concept. I think we all are well aware of this. Few definition, dissemination in space, which means having MS lesion in different regions, and then dissemination in time, which just means having MS lesion in different moments in time. This becomes very important because in the new criteria, they have tweaked around with these two concepts. Next, again, basic, we all know this, how we diagnose MS. We diagnose MS by clinical history. If someone comes to my clinic, they tell me story of clinical attack that can fulfill, that in my head makes sense that it can fulfill dissemination space and time, that counts as a true clinical attack of MS. We get MRIs where we can look for dissemination in space and time, and then there's another avenue for diagnosing someone with MS, and that's CSF testing. Previously, as we all know, only oligoclonal banding was included in the diagnostic criteria. But as per the 2024 McDonald's criteria, if you have CSF kappa-free light chain, that substitute for oligoclonal band. So that's one of the bigger changes. Moving forward in my presentation, anything that's in red is supposed to be the new update. So kappa-free light chain is the new update in the 2024 McDonald's criteria that substitute for oligoclonal bands. To be frank here, even in US, majority of the centers do not have the capability to send kappa-free light chains. So this is mostly done at research institutes and at very few places. We still are doing oligoclonal bands mostly. Moving to the next slide. So talking about dissemination in space over here, as we all know, per the 2017 McDonald's criteria, you need to have more than one or more than one T2 lesion in at least.
Dr.
two-
Atika, excuse me, please. Sorry for
Yes.
disturbing. If you put it on a slide mode, your slides will be more visible.
Okay, give me 1 second.
Yes.
I'm gonna pause over here and show.
Slide mode. Yes.
This one. Okay.
When it,
This
when,
one?
yes.
Okay.
Thank you.
No worries.
Thank you
Thank
very
you.
much.
Is that more better?
Yes, it is visible now. Thank you.
Okay. So again, dissemination in space, as we all know, in the 2017 McDonald's criteria, you need to have one or more than one T2 lesion in at least 2 out of the 4 regions, which we call topographical areas. The first location is juxtacortical or subcortical or intracortical. They all count as one region. This one, if you can see my cursor, is a good example of a juxtacortical lesion. And the next one, these ones are a good example of intracortical or a subcortical lesion. Then the next big location that we look for is periventricular. These ones are a classic example of Dawson's finger. These lesions are usually periventricular perpendicular to the corpus callosum, much better viewed in sagittal view of MRI. Next topographical area is infratentorial. So infratentorial is brainstem or cerebellum. You can see an example of a cerebellum lesion over here. There are multiple pontine lesion over here. And then spinal cord is the fourth location. You can see multiple C2, C3 lesions and then a few lower cervical spine lesions in this example. So these 4 locations were always have been a part of McDonald's criteria, even in 2017. In the new update, they added optic nerve as the 5th topographical area. So as we all know, optic nerve involvement in MS is fairly common. It's usually can be the first symptoms. It's usually short segment usually more in the interior part of the optic nerve. So now the criteria has the dissemination space has expanded to 5 topographical area. You only need to have, if you have, we will go in more detail about this, but if you have 4 out of the 5 regions present, you automatically have MS in per the new diagnostic criteria. We will talk more about this in a few minutes, but so that's the first thing that's new. Optic neuritis is now, optic nerve is part of a part of dissemination space. Moving forward, dissemination in time, which just means having lesion in different moments in time, meaning that you can have a non-enhancing lesion and an enhancing lesion present at the same time, which signifies that you have active inflammation going on at the moment. We all are well familiar with this concept, but this still stands. If you don't have an enhancing lesion on the MRI and you're still trying to confirm dissemination in time, you can confirm it with lumbar puncture. You can send the CSF for oligoclonal bands. Per the new diagnostic criteria, you can also send for kappa-free light chain index, which can substitute for oligoclonal bands. As I previously said, even in US, this is not done every day. This is far in between. But the old dogma that you can get that in the future, if there's a new lesion present, previous to the baseline scan, or a new enhancing lesion present, that just signifies dissemination in time. So now we have talked about dissemination space and then dissemination in time, and then kind of putting everything together and seeing side by side what the old criteria was and what the new criteria has added on. In the old criteria, which was last updated 2017, as I said previously, there were 4 locations, 4 topographical areas. Now a 5th location is added, which is optic nerve. For dissemination in time, you either needed a second clinical MS attack, or you needed a new enhancing lesion or a non-enhancing lesion, or you get CSF testing and check for oligoclonal bands. In the new criteria, the difference is there is a scenario in the new criteria where you don't even need to wait for dissemination in time, where if someone presents to you and is giving you a classic clinical attack history of MS, and you get their MRIs and they have at least 4 out of the 5 areas, the topographical areas involved, that is straight MS. That just leads to diagnosis way much quicker than previously. So that is one of the biggest, I think, one of the biggest takeaway from the new update. And then we have already talked about this. Dissemination in time had some changes to that is kappa-free light chain, and then instead of oligoclonal bands. Moving forward, I wanted to talk to you about just conceptually what central vein sign is, because again, this was included in the new criteria. I know not everyone does it. It requires more advanced MRI techniques and radiology's interpretations, but central vein sign is incorporated in the 2024 McDonald's criteria. What central sign is just it's a really sensitive tool to distinguish between a non-specific white matter lesion in the brain from an MS lesion. In the MS population, the white matter lesions have a perivenous inflammation, meaning if you look closely in the SWI sequences, you can see a thin vein that kind of runs in between the lesions. You can see a few examples over here. This one is a very good example. So it just signifies a perivenous inflammatory process, which the non-specific white matter lesions do not have. This is very specific to MS. Per the new diagnostic criteria, you need to have at least 40% of the lesions need to have central vein sign to be able to confidently say that this is MS and not a small vessel disease or something else. As we all know, even if you have MS, you will still have non-specific white matter lesions. People have other diseases, people have headaches or small vessel disease alongside MS. So this can still be seen. Hence, the cutoff was made to kind of at least 40% of the lesions should have it. And then the definition of positive central vein sign is the presence of 6 lesions with central vein sign. And this is kind of the language they wrote on the diagnostic criteria. I will move forward. Another concept to understand is paramagnetic rim lesion. Again, requires higher resolution MRIs and requires radiology's interpretation as well. This is also better seen in the GRE or the SWI sequences. What paramagnetic rim lesions are, they are basically what's get picked up by MRI are these iron-laden macrophages that surround an old chronic MS lesion. What they are showing are they're kind of an evidence of smoldering MS. This concept that even beyond the active phase of lesion, when it enhances and then loses enhancement, those lesions are still causing inflammation, and that is usually driven by microglia. In the MRI world, in the radiology's world, this shows up as kind of like a nice ring around a lesion. This one is a good example. The last one is kind of like, because it has iron in it, it's iron-laden macrophages that's getting picked up. It's better seen in the SWI or the GRE signal sequences. Again, it shows iron-laden macrophages eventually cause demyelination and axonal loss. Pathophysiology-wise, histology-wise, this shows up as a inactive core surrounded by all these active inflammatory cells. Paramagnetic rim lesions will become very important moving forward because they have been associated with more progressive forms of MS. Presence of even one or more than one paramagnetic rim lesion is associated with, highly associated with MS and can distinguish it from its mimickers with a pretty good high specificity of 99.7%, but had a low sensitivity. Again, these things, it will be some growing pains before these are all incorporated in our clinical practices. So moving forward, this is probably going to be one of the largest slides, and it's a busy slide. I apologize for this. But just a quick recap, 2017 criteria, you have typical MS symptoms, you get MRI, you confirm dissemination space by having 2 or more than 2 topographical areas involved, and then you get dissemination in time, either through you wait for a new enhancing lesion or you wait for a new non-enhancing lesion, or you get CSF testing to look for oligochronal bands, and you can diagnose someone with MS. So typical symptoms plus dissemination in time plus dissemination in space. Per the new diagnostic criteria, is straightforward. If someone walks into my clinic and gives me a history of typical MS symptoms, I get an MRI. For example, they have juxtacortical lesion, periventricular lesion, they have spinal cord lesions, or they had optic neuritis. That's straight up MS. I don't even need to do any further testing. The criteria becomes way more convoluted if you don't have 4 locations involved. For example, if you only have 2 or more than 2 locations involved, or you don't have a distinct clinical attack, but you're reporting a history of just clinical progression that is lasting more than a year, or you have presence of just spinal cord lesions, then MS can be diagnosed under these scenarios. Then you have to do further testing or wait a little bit longer. Either you get CSF and test for OCB or kappa-free light chains, or you look closely at the MRI again, see if you can find central vein sign. You need to find at least 6 lesions to have a central vein sign to say someone is positive, central vein positive, or you wait like the traditional way, you wait for a second attack. So things get way more complicated if you have less than 4. Another scenario, what if you only have 1 lesion? For example, this is very common. I see patients who are just have optic neuritis, right? And can you just diagnose someone who just came with the first episode of optic neuritis? So this scenario mostly applies to them. If you only have one lesion, lesion in only one space, or you have 12 months of progression, then MS can be diagnosed if these scenarios are present. This is still gets more complicated. Either you jump the gun, get a lumbar puncture, test for these things, and you have to have central vein signs, or you need to have a paramagnetic rim lesion. Because so these scenarios again, I hope you guys can read my screen. I can read it out too. But CSF oligochondral bands or kappa free light chain and six or more than six central vein sign lesions, or you can do CSF oligochondral bands or kappa free light chain and one or more than one paramagnetic rim lesion, or you wait for dissemination in time. But you need, even if you're waiting for dissemination in time, you still need to have six or more than six central vein lesion or one or more than one paramagnetic lesions present. So this is I think out of my entire presentation, this is probably the most important slide. Kind of summarizes what the whole update was. It's a little confusing, in my opinion, but it makes for easy MS diagnosis now. You don't, especially a vast majority of patients do have four or more than four regions involved. That's just my personal opinion. People who were previously classified as clinically isolated syndrome or radiologically isolated syndrome they actually fit the MS McDonald's criteria now. I think I do not have the time for clinical cases, so I will stop here for questions and see if anyone has any questions for me. Sorry.
Thank you, Dr. Atika. Are there any questions? I don't think, Dr. Atika, there is any question. Thank you very much.
No worries. Thank you so much. Thank you for your time.
Thank you, Dr. Atika, for explaining the new McDonald's criteria. I'm sure it will be very helpful for the residents for the upcoming exam as well. So we will now proceed to our next presenter. This is Dr. Nurulan, and she's from Fauji Foundation Hospital, Islamabad.
Assalamu alaikum. I'm Dr. Nurulan, resident neurology from Fauji Foundation Hospital. And I'm here to share our clinical experience and current understanding of multiple sclerosis and related demyelinating disorders based on our patients' data at FFH. This is the sequence of my presentation. Multiple sclerosis is the predominant disorder, accounting for 42 cases out of 60, making up majority of the demyelinating disease burden. Neuromyelitis optica spectrum disorder accounts for 12 cases, and MOGAD is least common with 6 cases, highlighting the importance of accurate differentiation of these overlapping syndromes in our study. Our demographics are consistent with the global trends, showing a clear female predominance, 84% compared to 16% male. The mean age of our cohort is 35 years. Geographically, our patients mainly hail from Upper Punjab, Kashmir, and KPK. Socioeconomically, the patient distribution is balanced between upper and lower middle class. Understanding the phenotype distribution is important for prognosis and treatment planning, as relapsing remitting multiple sclerosis patients are more likely to respond to disease-modifying therapies, whereas secondary progressive multiple sclerosis and primary progressive multiple sclerosis require more targeted and systematic approach. This pie chart depicts distribution of multiple sclerosis phenotypes in our cohort. For Gaussian view, we observed that relapsing remitting is most predominant form, accounting for majority of the cases. This slide shows the presenting symptoms in our cohort. As you can see, motor weakness and sensory symptoms are the most prevalent initial complaints. Sensory impairments with a proportion of 75%, accounting 32 patients out of 42. Second most common group is motor impairment at 59%. That is 25 patients had symptoms reflecting weakness and difficulty with limb movements. Optic neuritis constitutes 20 patients. Ataxia was least frequent, seen in around 5 patients, representing a smaller subset with a cerebellar involvement. Radiologically, our findings confirm classic MS patterns. The graphical representation shows 12 different patterns of radiological findings in our 42 multiple sclerosis patients. Periventricular combined with juxtacorticular or infratentorial lesions are the two most frequent patterns, accounting for over 30% of all findings. As well as periventricular lesions are the hallmark, present in nearly 86% of our patients. Spinal cord and optic nerve involvement are also frequent. It is rare to see single-site findings. The disease is fundamentally multifocal. The treatment profile in the cohort highlights a clear preference for targeted B-cell therapies like ocrelizumab and rituximab, with older immunosuppressants used a smaller portion of patients, reflecting both modern multiple sclerosis management and individualized care. The majority of patients received B-cell targeted treatments with ocrelizumab used in 19 patients and rituximab in 9 patients. Traditionally, immunosuppressive agents, leflunomide and azathioprine, were used less frequently. We analyzed the relapse rate according to the treatment type. Patients on monoclonal antibodies, ocrelizumab, rituximab, 5 out of 28 experienced lower relapse rate of 17.8%. However, those on oral disease-modifying therapies, 3 out of 14 patients had a slightly higher relapse rate of 21.4%. This supports the use of high-efficacy therapies early in the disease course. Shifting briefly to neuromyelitis optica spectrum disorder, we see severe bilateral optic neuritis and transverse myelitis in 80% of cases. The female predominance is even more pronounced, 10:2. Lastly, for myelin oligodendrocyte glycoprotein A antibody disease, this tends to affect a younger demographic, including children. Most pronounced clinical feature is acute disseminated encephalomyelitis alongside optic neuritis. This concludes my presentation. I thank you all.
Our next presentation will be by Dr. Zainab Memon from Aga Khan University, Karachi, and she has joined us on Zoom. Dr. Zainab, can you please unmute? We can't hear you.
Is that okay now?
It's okay.
Good afternoon, everyone. Assalamu alaikum. I am Dr. Zainab Memon, Fellow Neurology from Aga Khan University Hospital, Karachi. I'll be presenting a concise descriptive analysis of our multiple sclerosis cohort. There are no disclosures. This data set was compiled using patient records from HIMSS department at Aga Khan University Hospital, covering period from 2019 to 2024. Amongst 245 patients who were worked up for suspected multiple sclerosis, we included 49 patients in our study who had a confirmed diagnosis of multiple sclerosis. Patients who had incomplete clinical details were excluded, and so were those patients who were ultimately found to have alternative neurological diagnosis. This process is important to highlight because this underscores the broad differential diagnosis we encounter in patients suspected to have a demyelinating disorder. This population pyramid clearly demonstrates that MS in our cohort primarily affects young adults, peaking in the 25 to 35-year age group. This mirrors global epidemiological trends where most MS diagnoses occur between age 20 to 40. You will also notice that women consistently outnumber men across nearly every age band. This reflects the well-documented female predominance MS, while international studies reporting female to male ratios of approximately 2 to 3:1 in relapsing remitting MS. This pattern is attributed to hormonal, immunological, and genetic factors that influence susceptibility. The tapering of the pyramid in the older age group aligns with known data indicating that late onset MS, which is defined as onset after age of 50 years, is relatively uncommon. Clinically, these insights carry important practical implications. Number one, MS care must be heavily structured around the needs of working age adults. Number two, a substantial portion of affected individuals are women in their reproductive years, emphasizing the importance of gender-sensitive counseling, pregnancy planning, and therapy safety. Number three, the small but meaningful number of older individuals reminds us to maintain diagnostic vigilance in late onset presentations, which can often be under-recognized or misattributed. This slide is about the symptoms seen in patients with multiple sclerosis. This figure compares the proportion of patients who presented with each major symptom category at the time of the first clinical encounter with a broader array of neurological manifestations observed during their disease course, which is categorized as the other symptoms. The first symptom reflects the patient's initial point of entry into the healthcare system and often indicates the earliest clinically apparent site of CNS involvement, most commonly visual optic, motor, or sensory pathways. In contrast, the other symptoms represent additional neurological deficits that emerge later, capturing the evolving multifocal nature of multiple sclerosis. This distinction highlights that while initial presentations are often dominated by a single symptom domain, the cumulative symptom burdens expands over time, reflecting dissemination in space and the heterogeneous trajectory of multiple sclerosis. As far as the subtypes of MS is concerned, this pie chart shows that the relapsing remitting multiple sclerosis is predominant phenotype in our cohort, about 73.5%, which is again consistent with global epidemiology. Progressive forms, however, are fewer, but they still remain clinically important due to their rapid disability progression. The small NA group represents patients who were evaluated for suspected multiple sclerosis but were lost to follow-up before a subtype could be confirmed. This highlights a key real-world challenge, ensuring continuity of care so that early diagnosis and timely therapy initiation could not be missed. Now we'll talk about the MRI lesion distribution in the brain and spinal cord. This is a dual panel chart which summarizes the distribution of brain and spinal cord lesions in our MS cohort. On the left, you can see the expected predominance of periventricular, juxtacortical, and subcortical lesions, three hallmark regions central to MS diagnosis. These locations form the cornerstone of dissemination in space as outlined in the McDonald's criteria for multiple sclerosis. Infratentorial lesions also appear with moderate frequency, which is clinically meaningful as brainstem and cerebellar involvement is often correlates with some of the very disabling symptoms in our patients. On the right, you can see that the spinal cord lesion distribution, which shows that the cervical cord involvement by far is the most common pattern, consistent with international MS cohorts too. Thoracic and lumbar involvement is notably less frequent. We also have classified patients as no lesions on MRI or not available, and it's important to interpret these groups very carefully. Individuals without visible lesions may represent very early disease, partial imaging, or atypical radiological phenotypes. Not available reflects missing imaging records or incomplete uploads, highlighting real-world limitations in retrospective data extraction. This slide is about the presence of, about the abnormalities seen in the CSF testing and visual evoked potentials. There's disproportionate prevalence of oligoclonal bands, which is indicated as intrathecal IgG synthesis as the paraclinical abnormality. While in parallel, VEP testing reveals a high burden of optic pathway dysfunction, showing both unilateral and bilateral abnormalities collectively. Coming to the therapeutic landscape, one of the most striking patterns in our data set was the shift towards high efficacy B-cell depleting therapies. It is important to note that we had 9 patients who were initially on conventional disease-modifying therapies. They were later switched to anti-CD20 therapies for optimal clinical response. In our population, ocrelizumab is the most commonly prescribed agent, followed closely by rituximab. This trend reflects international evolution and the increasing comfort of clinicians in Pakistan with early high efficacy intervention consistent with the treat to target approach that aims to minimize long-term disability. It also highlights the changing landscape of MS therapeutics in low and middle income countries where access, affordability, and real-world effectiveness must be continually evaluated. This chart is the last part of the data. This maps the EDSS disability categories across the MS subtypes. What we observe is consistent with international MS natural history data. Patients with relapsing remitting MS mostly fall within the no to mild disability range on follow-up, which reflects earlier disease detection and the effect of disease-modifying therapy in limiting the disability progression. However, in contrast, moderate and severe disability levels appear more frequently among patients who had progressive subtypes of multiple sclerosis, which is expected as these forms of MS are characterized by greater rate of progression and limited therapeutic reversibility. You will also notice categories as not available or lost to follow-up in this part of the data, and these highlight practical challenges we face in longitudinal EDSS assessment, especially in patients who disengage from follow-up or have incomplete documentation. Altogether, this chart gives us a clear snapshot of how disability burden varies with the MS subtypes in our real-world cohort. This is a summary of the key findings in our MS cohort. Our cohort reflects classic MS patterns with motor presentation in about 31% of patients, visual in 25%, and sensory symptoms in about 14% at the onset of the presentation, and followed by multifocal evolution over time. We had about 59% of oligoclonal band positivity and VEP abnormalities found in about 51% of patients. And this was significant. This had a significant association, reinforcing diagnostic confidence. With respect to the radiological findings, MRI aligned with typical MS lesion topography with periventricular juxtacortical lesions in the brain and cervical cord predominance in the spinal cord lesion. RRMS, as expected, patients generally maintain low EDSS with higher disability clusters with the progressive subtypes of MS. And treatment, again, now favors high efficacy infusions. However, a meaningful group of patients still remain untreated or are lost to follow-up. And this, again, reflects challenges in access and continuity of care in our setup. The key message is that early recognition, complete testing, and timely initiation of therapy are essential to prevent disability accumulation. These are my acknowledgements. Thank you. That's all from my side.
Thank you, Dr. Zainab. We'll now move to our next presenter. We have Dr. Ahmed Wali from Arya Institute of Health Sciences, Quetta. He's a consultant neurologist, a neurophysiologist, as well as an interventional neurologist with the biggest data of CNS demyelination from Pakistan.
Assalamu alaikum. Good afternoon. Uh, Before presenting data, few points about my study and data. So multiple sclerosis is increasing globally, and especially in the South Asia and Pakistan, due to better MRI access and diagnostic awareness. Like 2015 तक हमारे क्वेटा में MRI की सिर्फ 4 मशीन थे और अभी 21 machines हैं in one small city. So the MS prevalence is also increasing in Pakistan, 10 to 15 patients per 100,000 population, and mostly in the young age, 20 to 30, with female predominant. So the real world data from Pakistan is scarce, and especially from the area like such from my province. Previously there was no such data. So we conducted a study at Sheikh Zayed Hospital, Quetta, on multiple sclerosis patients. Those were exclusively receiving ocrelizumab since June 2020. Before June 2020, these drugs were very frequently used: interferon, teriflunomide, azathioprine, fingolimod. But after that, in Quetta, in Balochistan, we started on ocrelizumab. In this regard, Pakistan Baitul Mal and Roche, they supported us very well. They started huge program on providing ocrelizumab with the partnership of government of Balochistan. So why we did this our study? So the rationale was that there was no real data, real world study in Pakistan on disease modifying therapy. Yes, people were using steroids, people were using azathioprine and other drugs, but there was no such a definite disease modifying therapy study. That's why we started. And the second thing, it was really readily available for us. And this regard, as I said before, Pakistan Baitul Mal Ehsas Tahfuz program in the previous government. And then finally, nowadays, we have Chief Minister Fund for Rare Disease. This fund provides different medications for cancer and other diseases, and one of them is multiple sclerosis. So from Balochistan, we took this initiative because when we were giving this ocrelizumab to patients, we did not see any adverse reactions. We did not see any major side effects, and it was easy to administer. So then we started the study. So before talking on my study, so the MS burden and flow in Quetta, Balochistan is like we have in daily OPD, in the neurology OPD, we have 10 to 14 patients per month of multiple sclerosis. This is of the latest trend from 2024 to 2025. And hospital admissions for multiple sclerosis is 2 to 4 per month. इसमें वो मरीज भी है जो नए डायग्नोसिस होते हैं और जो वो मरीज भी है जो फॉलोअप के लिए आते हैं. So what is the evidence about giving ocrelizumab? So ocrelizumab is the first and only anti-CD20 therapy approved for both RRMS and primary progressive MS. So the recent data, like from 2023 to 2024, it shows that it has a consistent reduction in the relapse rate as well as disability progression. This is mainly taken from the OPERA 1 and 2 open label studies. The long-term data also show that after 10 years of continuous therapy, we have 77% patients free from disability progression and 92% could walk unaided. But the one condition is that if you start it in the early disease process. Same as we have Oratero trial that was done for primary progressive MS. It also showed slow disability accumulation and overall slow in the brain atrophy rate. So the last in the Paktrims, the data that was presented, it also favored ocrelizumab, that it has superior relapse control compared to other high efficacy drugs such as natalizumab, fingolimod, and alemtuzumab. Safety is also good. We have a very famous trial, Confidence. 2024 report says it has acceptable tolerability. Some say that there is decline in the serum immunoglobulin levels, but that's not very drastic. I have taken this slide from the Roche. Like this is the mainly Opera 1 and 2 trials. When it was not open labeled, it was compared with the interferon. But after it was made an open label study, you can see that there is consistent reduction in the relapse as compared to the interferon. So the annual relapse rate, there is ARR, is 0.017 of the ocrelizumab as compared to the other interferon. So very, very low relapse rate. Regarding our data, before July 2024, we were managing these patients mainly from 3 funds: Baitul Mal, Ehsas Tahfuz program in the previous government, and then MSD Balochistan. MSD Balochistan is Medical Supplier Division. This is government of Balochistan division for supplying medication free of cost. So MSD, Baitul Mal, and Ehsas Tahfuz program, all of them were giving Ocrevus free of cost. But in the late 2024, then the Chief Minister's Special Fund came. After July 2024, all the patients were shifted to CM Special Fund. Because then in the presence of this CM Special Fund, we quit other programs. So total up to now, we have 32 patients. But one thing is very important. In Quetta, Sheikh Zayed Hospital is not the only hospital. This is only the data of my hospital. We have a very big tertiary care hospital, that's Bola Medical Complex Hospital. They have their own data. Professor Amanullah Sahab is sitting with us. Their patient is, I think, crossed 50 number, more than 50 patients. So the study which I did exclusively on patients that were coming to Sheikh Zayed Hospital. That is 32. When the Ocrevus was started back in June 2022, it was started first by Dr. Wasim Wali in the CMH. But they don't have their data. So we cannot say how many patients were treated in the CMH. So until July 2024, we had 21 patients, but now we have 32 patients. It means that in 1 year, only one center, that is my center, Sheikh Zayed Hospital, it has received 11 more patients. So this is roughly, you can say that our tertiary care hospital receives new 10 to 11 patients or 10 to 12 patients per year. So as I said that when we started this real world study, then I searched how many studies were done. So there were many studies, real world studies. At least 52 publications were there on the real world study. So we enrolled our patients, all adult 18 to 15 years old. We used 2017 McDonald criteria, and Ocrevus, ocrelizumab, we gave it after 6 months. 600 mg. The first dose was split into 300 and 300 with 15 days gap, but the second dose was then 600 mg as a whole. So all patients underwent a scheduled examination after 3, 6, and 12 months after receiving Ocrevus. These were the findings of MS patients. All of them, of course, they were fulfilling somehow criteria for the MS clinically. All of them had evidence of multiple sclerosis on MRI. OG bands, only 12 patients had OG bands positive, and 6 patients had only this VP positive. So the predominant symptoms were ataxia, sensory symptoms, visual symptoms, and then paraparesis, paraplegia, bladder symptoms, bulbar symptoms, quadriplegia, nystagmus, bowel symptoms, speech problems, and numbness of fingers. After giving Ocrevus ocrelizumab, almost there was improvement in all symptoms, but most of them, ataxia and paraparesis were improved the most. After that, hemiplegia, spasticity, sensory, bladder, these symptoms improved after giving this Ocrevus. These are the type of MS. Majority are RRMS, 24. Then we had primary progressive 4 patients. We have clinical isolated syndrome 2. The reason why we give Ocrevus in a patient with clinically isolated syndrome, because we thought that we should not waste the time. We could not wait for the second attack. We don't know if it will remain clinically isolated or not. So that's why, and we had readily available Ocrevus, so we gave Ocrevus to these patients. And the 2 patients were there, of which the findings were overlapping. So in the MRI, some findings were favoring RRMS, some findings were favoring NMOSD, but we gave Ocrevus. This is the very important thing that we observed in our study, that the EDSS decrease, it is almost 1.8 decline in the EDSS, improvement in the EDSS. When we compared our study with other real-world studies, it is kind of strange that our EDSS change, improvement was 1.8. But other studies, all of them were done, that was only 0.2 to 0.3. Now we don't know. This is the exaggerated response from the patients. This is the response of our patients to Ocrevus of our region. We don't know. That's why the EDSS has improved so much drastically as compared to the other studies. So this is a comparison of my study versus other big trials. Of course, my number is very small. Only one center, 32 patients, as compared to the patients that were enrolled in the Confidence and the Opera 1 or 2, that was in thousands. The important thing that you can see that again, that the relapse rate is similar compared to the other studies. That is very low or minimal relapse. So in 32 patients, only 2 patients had relapse. That relapse was not very much disabling, only numbness face, numbness hand, or numbness lower body. If we check the EDSS, as I said before, my EDSS decline was from 5.25 to 3.3.
So you have 2 minutes to complete your.
Yes, this second last slide. So the EDSS improvement was very, very prominent. This is the satisfaction level of the family and the patients. The side effects, almost we did not observe very drastic side effects. Only 2 patients got severe pneumonia, other got restless leg syndrome, weight gain, recurrent UTI, depression, and allergic to Ocrevus. There was none. There was nobody who had allergy to Ocrevus. This is the ethnicity, because Balochistan has multi-linguistic area. So this is the ethnicity: Pashtun 16, Baloch 14, and Hazara 2 patients. Thank you.
Thank you, Dr. Ahmed Wali. We'll now move to our next presenter, Dr. Hafsa from KRL Hospital, Islamabad.
Assalamu alaikum. I'm Dr. Hafsa, resident neurology from KL Hospital. I appreciate this opportunity to present my experience at KL Hospital for demyelinating disorders. KL Hospital is a tertiary care private sector hospital, which constitute initially 377 bedded tertiary care unit, which was added by 329 bedded second unit in 2024, and constituting Abyssinia Medical Complex. KL Hospital in Islamabad includes neurology department as among its various specialties. As its journey since its early days has expanded, it has transformed from a small subspecialty into a recognized department. And it got its accreditation from CPSP in 2024, and currently there are 2 consultants and 3 neurology residents. This is neurology patient record for the last 5 years. The blue tabs are showing the OPD patient influx, and the green tabs are showing in patient admissions. Our study has spanned from January 2021 to November 2025, with the inclusion of all the patients presenting to neurology in patient as well as OPD with a suspicion of CNS demyelinating disorder, with exclusion of a patient under 13 years, including both genders. The patient burden of demyelinating disorders presenting to us were 19 patients in all, and among them, 31% were diagnosed with multiple sclerosis, 26% with clinically isolated syndrome, 21% patient with neuromyelitis optica spectrum, and 31 with miscellaneous. Among multiple sclerosis subtypes, majority were relapsing remitting subtype, and 1 patient was primary progressive and 2 patients with secondary progressive MS. Among clinically isolated syndrome, 1 patient was diagnosed short segment myelitis and 4 patients had optic neuritis. Among neuromyelitis optica spectrum, 2 patients were seropositive and 2 were negative. Among miscellaneous group, 2 patients had Adam, 1 patient had radiation myelitis, 1 patient with subacute combined degeneration, 1 patient post-infectious dengue mellitum, and 1 patient TB myelitis. Gender distribution, there is equal gender distribution observed in multiple sclerosis and NMOSD. However, there is male predominance in clinically isolated syndrome. Age distribution, group A ranged from 13 to 35 years, had the major constituent of the patient, 63%, and 35 to 60 age group had 36%. Case distribution, again, this is the pie chart presentation of the previous 31% of the miscellaneous group, 31 of the multiple sclerosis, 26% with NMOSD, and 21 with the clinically isolated syndrome. Among all the patients presenting to us, the patient with the optic neuritis, 4 patients had unilateral unilateral presentation, 1 patient had bilateral, and 1 patient had recurrent. Transverse myelitis, 4 patients had longitudinally extensive myelitis, and 1 patient had short segment. Serological markers, oligoclonal bands were present in 4 patients, and aquaporin 4 were present in 2 patients. MRI findings, majority, all the patients of the multiple sclerosis had periventricular lesions. Just a cortical and cortical were present in 5 patients. Brainstem was present only in 1 patient, and spinal cord lesions in 6 patients. Radiological findings of our patients, we had selected few patients for presentation point of view. These are the MRI showing periventricular hyperintense multiple foci of demyelination. Confluent linear periventricular hyperintense multiple foci with vertical orientation. This is MRI spine showing abnormal signal intensity extending from C5 through T7 with swollen cord and showing patchy enhancement. post-gadolinium T2. This is again another MRI spine, just showing abnormal signal, longitudinal extensive myelitis extending through the cervicothoracic cord with patchy enhancement. MRI brain orbital view showing abnormal signal intensity in right optic nerve. This is I hope I have. This is from the patient of radiation myelitis. The cervical and thoracic cord are swollen and expanded and extending superiorly into the medulla, showing post-contrast patchy enhancement. Treatment data. All the patients were given short-term therapy with IV methylprednisolone. Regularly dosed methylprednisolone was given to our one patient in follow-up from the outsource. Plasmapheresis was given to 3 patients, 2 of the ADEM and 1 of the radiation myelitis. And IV immunoglobulin was given to 1 patient post-infectious myelitis. For disease-modifying therapy, Ocrevus was given to all of the 6 patients of multiple sclerosis, 3 females and 3 male, and they were equally responding, and there was no relapse since the start of the Ocrevus. Rituximab was given to 1 NMOST patient who was seropositive, and there were no follow-up relapse, and she is currently following us. Azathioprine is also giving in 1 NMOST patient. I didn't do that. I didn't know. Okay, आगे. ठीक है, आगे. Azathioprine is being given to one of the neuromyelitis optica spectrum patient who is aquaporin 4 positive, and MRI is positive for optic neuritis and longitudinal extensive myelitis. And she's also not having any relapse since the start of this medicine. So we didn't have to change it to any other option. This is one of the patients who is in our follow-up. Initially, she was started on monthly pulse, Solomedrol, from 2014. But when she had a new attack in 2021, she presented to us, and then we had started Ocrevus, and since then she has no relapse. This is the outcome of all the patients. 10 patients had complete recovery, 8 patients had partial recovery, and 1 patient of radiation myelitis had unfortunate AC event. Thank you.
So this brings us to the end of this session. I would like to ask over the chairs and co-chairs for any comments.
Thank you very much. So I think the session went very well, and we heard a very good data from different institutes. And I think, as my other colleagues remarked, if we start presenting this, if publishing this data, it would be a great number, and it would be a great data from Pakistan if we start publishing it. I think it was really a good data. So it should be published.
Thank you very much. Ma'am has already said about the data. The first presentation was about the diagnostic criteria of 2024. So most important thing is, one is to make the radiologist aware of this criteria, though my few friends already knew it. But in second is the availability of the MRI machines that can detect these lesions. So ideally, I think it should be at least 3 Tesla. And here we are still doing it at the 0.5 Tesla at few places. So definitely if it increased the specificity, and no doubt it was a very good session. And thank you everyone for inviting us.
Thank you very much. I just have a question from Dr. Nurul and from Fauji Foundation. Most of the chunk of the patients presenting there are females. So is that a confounding variable once we talk about the gender distribution of demyelinating disorders presenting to the Fauji Foundation Hospital? All right. Thank you.
Okay, so this brings us to the end of this session. I would now like to invite Dr. Amanullah Kakar, who is a consultant neurologist at Bulan University, Quetta, and President Movement Disorder Society of Pakistan, to please present the certificates. Okay, he's the ex-president of Movement Disorder Society, Pakistan. Okay, so the first certificate is for our chair and co-chairs, Professor Dr. Naila Shahbaz. Dr. Sadaf Nasir. Dr. Zishan Munawar. And now the certificates for our presenters, Dr. Nurulan. Dr. Ahmed Wali. Dr. Hafsa. Dr. Samar. Dr. Bilal. Dr. Asmat. Dr. Saad Ali. Dr. Kurutalan. Dr. Javeria. Dr. Amina. And Dr. Ifra. Thank you, sir. So we have a 10-minute prayer break, and then we will join back for the last session of the day. We see you after 10 minutes.
in 5 and area post
out of constraint pawns in 4. These are few scan
to travel for Karachi.
Okay, we'll now proceed to our last session of the day. This session will be chaired by Dr. Amanullah Khan Kakar Saab. And it will be co-chaired by Dr. Ikra Athar. She's a consultant neurologist at PAF Hospital, Islamabad. Dr. Neelma Naz, she's a consultant neurologist from Pakistan Institute of Medical Sciences. And Dr. Anam Irfan, who is a consultant neurologist at Maroof Hospital, Islamabad. Okay, so first presentation of this session will be by Dr. Sadia Nishad. She's from SIUT Karachi, and she has joined us on Zoom.
Yes. Presentation.
Okay, Assalamu alaikum everyone. And I'm so glad I'm in the constellation of stars of neurology out there. I wish I was there. Assalamu alaikum, Dr. Wase, Dr. Naila Shehbaz, and hey Dureshahwar and Ahmed Wali. I'm so glad I'm here. And thank you, Dr. Haris, for inviting me over and giving me this last chance. My presentation needs to be filling up really big shoes. You guys have done an amazing job, some amazing presentations coming from the residents, the faculty, amazing job. The kind of data coming, yes, everybody was right in the morning that let's write about it and why have we not written so far. So moving on, I have no disclosures, nothing to reveal except maybe my data was kind of pretty long. So this is SIUT, where I'm working for the last 9 years now almost. And we started neurology department in 2016. Dr. Mohit Shirani is the head. It's a free care. We are the largest transplant center in the region. We've done about more than 7,500 transplants, life-related renal transplants. Of course, we also do liver too, but not those big numbers. So it's a healthcare, which is a model which is talking about the community, the government, the patient. Everybody has a right to enter the gates of SIUT, regardless whether they're coming in their Audi or they have sold their cow and joined us and come for the treatment. All we expect from them is to come over. The doors are open. We'll do the treatment. The onus will be on us if we do not. SIOD has allowed us to carry on the demyelinating diagnostic dilemmas and to carry on with their treatment. So I'm not talking about anything specific or special here. Across the board, throughout the day, from the morning to night, females have been predominating this demyelinating disorders. And it's always also present all over the world as well. Where do we get the number of patients coming from? Located in Karachi, Sindh being the biggest number. Of course, we do get patients from Gilgit-Baltistan and across the border from Afghanistan. 2 of our patients really wanted us to treat them. So I do not have a big number of MOGAD. The number of patients that were shown here in Punjab, amazing, great job, Islamabad. I mean, your diagnostic criteria, agreed, amazing. What we saw was 77.8% of multiple sclerosis patients. Our NMOSD was only at 18.5%. We saw this MOGAD maybe at 0.6, maybe a patient or 2, and then Cryon, another 2 patients. There are overlapping syndromes as well. Sometimes you're just scratching your head off and wondering, what should you do next? Is this really demyelinating or this is another entity? The mimickers were well defined by the Khan report presented by Dr. Zainab. So what was our cohort? So from 2017, that's the data that I have. From 2016, we did see patients, but I do not have my data. I'm sorry on that. From 2017 up to present, we've only seen 160. It's kind of a modest data, not a big number. So the mean age was 32 years. Yes, we do get to see pediatric patients as well. as pediatric neurologists do send their demyelinating diseases patients to Dr. Mohis for an opinion, and then for the amount of treatment and the financial burden which is off from the patients are referred to us. We do see confirmed and sometimes suspected demyelinating disorders, which is the dilemma of all of us across the region. We've done steroids, azathioprine, leflunomide, and maybe I thought I would be talking about my rituximab. So we've given 142 patients receive rituximab from 2017 to 2025. 20 of our patients did not, partly because of the fact that it was the comorbidities of something else was coming up. There was a diagnostic dilemma, and most importantly, they were lost to follow-up. So there was observation on that. Symptoms profile, everybody talked about hemiparesis. So this is all nothing new. Just a slide to show that, yes, this data is consistent all around. Dr. Vasi talked about cognition. Yes, sir, you're right. We need to put it up. I talked about behavior change more so here. So what the numbers show on this slide is not the number of positivities. I should have put that up. What it talks about is the number of investigations that were brought to us with the brain imaging, the spine imagings being more predominant. For anti-MOG, we just brought it up last year. We asked our immunology department, and they were kind enough to bring anti-MOG to us. We checked that. Equiporin antibodies been present with us for a couple of years. And yes, we do have the autoimmune encephalitis. And today in the morning, they talked about the dual nature of these diseases as well, and we should not overlook this. What were the treatment options? We gave azathioprine in 37%, leflunomide in 24%, and we followed a rituximab protocol. This is a standardized protocol, and we have been burnt with the pregnancy and the breastfeeding. Patient took rituximab and then called us up and said that she was pregnant. So now we make it a point that we get the pregnancy test in 1 day before they come to us. So those are standard of 1,000 milligram, week 2, week 0, 2, and 6 months. We do check the JC virus testing, and I'm so glad one of my colleagues from KPK, if I'm not wrong, they picked up JC virus and it was positive. So far, we've not picked up any JC virus, and we only tested in patients who have crossed 7 doses. The number of doses, maximum number of doses, which one of our patients has received is around 11. There is rehabilitation in SIUD. We do that. We check the EDSS documentation. And once they have a relapse, you always go back to steroids as the treatment in between. So at 6 months, we have about 48.2% patients following up, but let's be honest, we do have a loss to follow-up patients of 24.1%. 2.8% of our patients expired. Now, I would not say this was only because of rituximab. This could be because the disease was already progressive. They were lost to follow-up. We had to call them up on the phone and ask about those patients. This is my EDSS. So our EDSS prior to rituximab was from between 4 to 6, and it brought down to around less than 2. Sometimes we even see around 1, 2. And we've seen this significant difference after the 4th to the 6th dose. The relapse rate is 9.2%. This is only for rituximab. Remember, this is only for rituximab, not about those patients who did not receive rituximab. What was the safety of patients on rituximab? What were the things that they noticed having? One of our patients had tuberculosis. This was a young girl in her late teens, took the rituximab infusion and developed hypertension. We said, we'll give you a second dose as well and give it a try. Start with a slow infusion. Her blood pressure shot up. She was out of the protocol of rituximab. And one of our patients had MI, and we asked his cardiologist, can we go back to rituximab? He said, no, he's out of it. And the patient has psoriasis. Infusion-related reactions are present in about 5.4% of our patients. So we check JC virus after the 7th dose, so hence the number is pretty small. 7.4% patients got their JC virus checked, and it's negative. So SIUD data is kind of maybe not different. The only difference is that they should not come to us because of their financial burdens. They should be not coming to us because of something else. We do not charge them anything. We just want them to come over and have it. We've been using rituximab since 2017. The reason because rituximab is easily available at SIUT, has been given for induction therapy, post renal transplant for oncological patients, for a graft dysfunction in transplant patients, and for both our oncological and nephrological patients. Post rituximab, we check up for infections, the JC virus, maybe that could be one of the different things. So it's a long term, it's easy to follow with us. If they want to, if there's something else that they don't want to continue, that's something else. But our doors are open. We'll do check their MRIs, we'll do their imaging, we'll do check their JC virus, we do the VEP. We have 140 patients been coming to us for the last 7 to 8 years on rituximab. It's not affordable. Yes, there's not present on the Sehat card, but yes, we can generate world-class data. That's roughly about finishes up my presentation for today. Thank you very much.
Dr. Dureshahwar, thank you very much. Excellent data, excellent presentation.
Thank you, sir.
Dr. Sadia.
Sorry,
Ji,
Dr.
sir.
Sadia.
That's okay, sir.
And Dr. Sadia,
Yes,
you
sir.
have the largest data of rituximab maybe in the region, or maybe one of the largest in the world. When do you think you will be able to write it up and publish this data?
Sir, you have been after me for a long time, and
Every year I
everybody
have
is
to.
too. Yes, and it's high time that I did. Now I have everything together thanks to Paktrims. They made me write everything together, bring it all up. All I now need to is present it up. I have, to be honest, sir, which is such a big audience sitting there, I did send it to AN, and for 2025, it was picked up. They selected it, but I had to withdraw because I was not able to travel. So yes, you're right.
Thank you, Dr. Sadia, for such an energetic presentation. You actually
Thank
woke us
you.
all up. Thank
Okay,
you.
thank you.
Okay, we now move on to our next presentation. It's by Dr. Dureshahwar Kanwar. She's an American Board of Clinical Neurology as well as Neurophysiology. She's a board certified neurophysiologist. She's also the program director of Clinical Neurophysiology Fellowship at Aga Khan University and the director of Neurology Residency Program at Aga Khan. She will speak on anti-CD20 therapies in CNS demyelinating disorders.
Thank you, Dr. Waheed. So I'm going to be going through CD20 therapy and demyelinating diseases. I don't have any disclosures or conflicts of interest. And just to give you an outline, I'll be going through the medications that are currently used in MS, as well as the treatment goals that need to be achieved. A single clinical scenario will be there, and then we'll study on CD20 B cell concepts and how they can have certain adverse effects. So, after the diagnosis of any demyelinating disease, two prevailing treatment strategies actually exist in practice. There's one way to approach the patient either through an escalation approach, or you can go through an early high efficacy or intensive approach, which basically means you start out with the best possible treatment available. The other option is that you sort of escalate upwards and go upwards from a drug that is relatively less used but has good efficacy as well. It has to be a shared decision because of the fact that patient preferences are usually based on the fact that they want to get better, but they also want to avoid all possible side effects. But they tend to prioritize a reduction of disability, the annual relapse rate, and the MRI outcomes are generally on the backhand of their priority. However, with providers, healthcare providers generally like to prioritize the annual relapse risk as well as the MRI changes that might be there on the scan. So a number of medications, I'm not sure if it's projecting well, but there's been a number of medications that have been used from the initial days. We used to have interferon during our residency days, and we used to also use mitoxantrone back then. But with the advent of the monoclonal antibodies, their use has relatively gone down. And generally now we tend to concentrate more so on IV medications as compared to the oral ones. So what is the treatment goal? So the treatment goal is that you do not find any evidence of disease activity, which is NEDA. NEDA 3 is basically defined as absence of new or enlarging T2 lesions or T1 contrast enhancing lesions on MRI brain. The second point is that there is no confirmed disability progression or an increase in the EDSS. And the third is that there shouldn't be a relapse. A relapse is when you get clinical symptoms which are identified for at least 24 hours and within 7 days of onset of symptoms. So if those three things are there, then you will probably label that the patient has NEDA. And another additional point or entity that contributes to the treatment goal is whether there is brain volume loss. The inflammatory response sort of matches with the above 3 points, but the brain volume in the long run talks about degeneration. So brain volume loss is another entity that needs to be looked at. And usually what happens is anything above 0.5%, 0.4% is considered to be abnormal. So 0.5% से लेके 1.35 तक initially MS patients में recognize किया गया है. So the brain volume loss is identified through certain categories. There's a 2D contrast Sienna method is used, and there's a basic formula that is sort of matched up, and previous scans are sort of matched to the current scans, and then you take out the loss in the brain volume. In healthy volunteers, 0.1 to 0.3% loss is considered to be normal. So this is a clinical case that I saw in my clinic. It was way back in 2019. She was a 43-year-old female who had actually shifted from Islamabad to Karachi for work. She presented in the clinic with complaints of fatigue for 6 months, and she also had a worsening gait and cognitive difficulty for 3 months. She was working in an oil company, and it was an office job, but she felt she had difficulty in concentrating, and for which she took a few days off work and noted there was also associated pain in her lower limbs, but there was no other focal deficit. She was a smoker, occasional alcohol user, and had diagnosed hypercholesterolemia, but she wasn't on any treatment for it. Her vitamin D levels at the clinic visit were below normal. So the pertinent findings on the CNS clinical examination were that there was a bilateral end-gaze nystagmus, there was a right finger nose dysmetria, the tone in the lower extremities was increased with hyperreflexia. However, the plantars were downgoing and there was a wide-based gait. When we got her MRI done, if you can see, there were multiple hyperintense lesions. The first one is a T1 axial image, which shows black holes, but it doesn't show any other lesion. And most of these are located in the periventricular area as well as the right frontal region. The second image is of an axial flare, and you can see the hyperintense lesions that are there periventricular seem to be multiple in number, and they're also affecting the trigone area. Corpus callosum के साथ वाले area. However, on the contrast scan, which is the last image on the screen, it does not show any enhancement in any of the lesions. This was the formal report that was done. And this is a sagittal flare of the same patient, and you can see the corpus callosum being involved and the Dawson's fingers that can be identified, the hyperintense lesions that are there. This was way back September 2019. We did a visual evoked potential on her, even though she did not have any clinical optic nerve involvement symptoms. And what you can see here on the screen is the first image is of a left-sided visual evoked potential, and the P100 value is at 115. However, the right side shows a P100 value of 123. I'm hoping you can see it. This is 115 and this is 123. And the normative is considered to be 116 for our lab. So 123 was prolonged, and this suggests that there was right-sided pre-chiasmatic optic pathway dysfunction. When we did the CSF of the same patient, there was slightly elevated proteins, and there was a 14 WBC count, and the predominant cells were lymphocytes. Oligoclonal bands were positive in the serum and in the CSF and absent in the serum. So we basically labeled the patient as a case of relapsing remitting MS, and pulse steroids were given to improve her clinical symptoms, which did after 5 doses of IV methylpred. When we discussed the same with the patient and the treatment options, she felt she did not want to be on IV medications, and therefore we had to sort of start her on teriflunomide. We started on teriflunomide at 7 mg initially and then increased it to around 14 mg, and this was in December 2019. She had some concerns, personal reasons for which she did not even want the diagnosis to be disclosed to her family who was here in Islamabad. She claimed she felt better and remained steady for around 1.5 years or so. And when she felt there was some worsening in the ataxia, she had an MRI in between, but I haven't put in here just for time concerns. However, the disease did still respond to the IV steroids. So this was a scan that was done in June 21, and you can appreciate the lesions that are there on the second slide. They seem to be increased as compared to the previous ones that I showed you, and there was some ring contrast enhancement on the post-GAD scans. So if you see the lower part, which is the official report, there was an increase in the overall enhancing lesions as well as the T2 burden severity. And there were new T2 lesions as well, and therefore it was reported as active demyelinating disease despite of being on Obagio for the past 1.5 years or so. In this case, the sagittal flare showed the same. And when we discussed the case with her, we felt that she now needed a transition to monoclonal antibodies. And we gave her the option of deciding between rituximab or ocrelizumab. Reading up the side effects on her own, we explained to her the same, and she chose that she would prefer to be on IV ocrelizumab, which we did start after all the prerequisite testing as well as vaccinations. She remained stable for the next 2 years or so. However, she left her job, the company had some shift, and she moved back to Islamabad. So the last scan that she had was in 2024. And when I was making this presentation, I spoke to her over the phone, and she said she's been doing well. However, she is completely off treatment. So since she was at AU in 2023 or so, she hasn't been on any treatment. So I told her, I sort of urged her to not do this and try to get a new scan as soon as possible and see a neurologist. So the anti-CD20 monoclonal antibodies that are currently available for use in MS include rituximab, which is off-label, ocrelizumab, ofatumumab, and oblituximab. So this slide basically shows how they've developed over time. So rituximab was initially used in the late 1990s for lymphoma and other hematological malignancies. But with progress, what they did find was that it had importance with use in relapsing remitting MS as well as progressive MS, primary progressive MS. But this was shown over a couple of years, and in the early 2000s, there were certain trials that were done, and I'll be looking at them in a while. But currently what's happening is there's been a recent shift from IV use of monoclonal antibodies to subcutaneous use. And they say the subcutaneous use appears to have better compliance, and also the human antibodies that develop with subcutaneous drug seems to be less as compared to the IV ones. Potential immunological action of anti-CD20 antibodies is basically through a target CD20. I won't go into the details because I know the time is such we don't want to get into a lot of details. But what's happening here is it's a transmembranal phosphoprotein, and some part of it is intracellular and some is extracellular. And these epitopes जो हैं वो are different for each of the 4 monoclonal antibodies that we'll be discussing. Important to note is that the CD20 monoclonal antibodies tend to spare their effect on stem cells, plasmablast cells, and plasma cells, and they tend to start their effect from pre-B cells, which is slightly after the CD19 appears. So the CD19 appearing cells come before the CD21s, and that becomes important for certain therapies. So how do these work? They have a number of mechanisms through which they can act and cause an improvement in disease. It's either through an antibody-dependent cellular toxicity, complement-dependent cytotoxicity, and the above two mechanism of actions sort of apply to the type 1 monoclonal antibodies that all four of them are. The ones in clinical use currently are type 1 monoclonal antibodies, and these basically change the lipid, the CD20 into a lipid form and a lipid raft form. That is the actual difference between the type 1 and the type 2 ones. And they have a different mechanism of action. So the type 2 tend to act through programmed cell death as well as through phagocytosis. So anti-CD20, as you can see, जो पहली है वो rituximab की sequence है, and that shows that it's basically chimeric. It has a murine part and it has a humanized part. And the humanized part is associated with the FC segment usually. And what happens is with ocrelizumab, it's humanized, but the one that is ofatumumab, that is completely human. कुछ बीच में आ रहा है स्क्रीन पर, यू रिसीव्ड रिक्वेस्ट रिकॉर्ड द क्लाउड, ये डिनाई करना है कि कुछ लिखा हुआ आ रहा है इस पे। कुछ होता नहीं रहेगा, वो घूम रहा है, ठीक है। तो ofatumumab is completely humanized, completely human, and however what happens is it acts through the immune system in mice. So it's sort of what it does is it decreases the immunogenicity, but it does not actually decrease the amount of infusion related reactions with all these humanized or human antibodies. Another important thing is कि जो ये सारी monoclonal antibodies हैं, they haven't been tested with each other except for mainly rituximab as well as ocrelizumab. There have been a number of studies that sort of compare the two, and ocrelizumab seems to come on top each time. So there, some of them are the Overlord MS study as well as the Dan norm study, and there's a number of other ones which I have difficulty in remembering, so I won't go into that. Rituximab, the first one that's actually been used, and most of these were studied by people in Sweden. So the Scandinavian countries have a lot of MS burden, and the studies that were done initially with rituximab were done in Sweden, and those are the ones that are mostly quoted. So there was the first one, which was helping to evaluate Rituxan in relapsing remitting MS. And then there was another one, which was safety and efficacy of rituximab in primary progressive MS. And what they found was that there was significant reduction in the number of contrast enhanced lesions on MRI brain after giving it for a certain number of weeks. And there was also a significant decrease in the annual relapse rate. So rituximab dosage, etc., have been discussed by Ahmad and Sadia as well, so I'm not going to go into that. Ocrelizumab is important because we've been using ocrelizumab from 2017, and both of the major agencies like the European Medicine Agency as well as the FDA from the US approved them in the same year. The terminal half-life of ocrelizumab is around 26 days, and the development of human antibodies is rare because it's humanized. That's one reason for it. Ocrelizumab, however, you have to, a lot of things that were looked upon on the major studies that were done with ocrelizumab, that is the OPERA 1 and 2, the annual relapse rate and the continued disability progression, as well as the NEDA achievement. A lot of things were looked at, but basically the main conclusion was that the annual relapse rate, the disability progression, and the contrast contrast enhanced lesions all had a very significant p-value. And therefore, the use when it was compared to interferon, which was standard of care pretty much back then, was changed. And we tend to now focus more so on the monoclonal antibodies, both for RRMS as well as primary progressive. Some other studies that were done with ocrelizumab compared them with placebos, and the extension of these studies sort of showed the same thing, that people who had been on ocrelizumab for longer tend to do much better as compared to people who switch from other medications to ocrelizumab once the disease has progressed. So it's always better to start off with intensive therapy for now, at least. The initial dose of ocrelizumab, Ahmed ne bataya tha ye, so I won't go into it. And the new thing is that ocrelizumab, the subcutaneous form, has been approved by the FDA last year, and hopefully it'll be available soon for use in Pakistan as well. The advantages of having a subcutaneous medication for MS would be the patient would be in the days to come be able to get their own medication at home. But in the initial phases, at least, you will need to come to the hospital, but the amount of time that you need to spend here would be less as compared to the current IV infusion. So if you look at the downward table that's there on this side, you can see that the first injection needs to have pre-medication like the IV forms, but this time you need to give them oral steroids as well as paracetamol and an anti-allergic. The injection takes around 10 minutes, and the post-injection monitoring, however, should be there for at least 60 minutes for the first dose. It's a single dose, you don't need to split it, and the dose is around 920 mg or 23 units, and this time it's actually combined with hyaluronidase, and it's given around the abdomen. So hopefully once we start using it, we'll have a better idea how it works. But at least the studies that have been done and the data that's currently available says that possibly in the future, we will completely shift from IV to the subcutaneous form. Ofatumumab again induces both the antibody-dependent as well as the complement-dependent systems. It's fully human, but still it might have some antibodies that develop with it. It's a subcutaneous dose. People do not need to come to the hospital for it, but it's extremely expensive. And to the best of my knowledge, it's not available in Pakistan. I guess so. I'm pretty much sure it's not available. But however, with this, it's good because you do not need any pre-medication because the amount of infusion-related reactions is very minimal. It again has been studied and compared to other medications as well as placebos, and it appears to have a good significant reduction in both the contrast-enhancing lesions as well as the relapse rates. Obinutuzumab, another one, the advantage that I saw with this was it's a very fast-acting monoclonal antibody. It tends to decrease the CD20 cells very fast within 24 hours, that has been quoted. And again, it's an IV dose that's repeated every 6 months or so. But this time it has a very great concentration in lymphoid tissue, and that is one of the mechanisms that's actually missed by the monoclonal antibodies because the area that they tend to proliferate or go into is less in the lymphoid tissue. Again, compared with a lot of medications, teriflunomide, and it seemed to have a better effect. But the ultimate 1 and 2 trials that were done on obinutuzumab additionally saw that there were certain infections associated with it, and some malignancies were also reported. Waheed, मैं time में हूँ या मैं? I'm okay. Let me know if I need to stop. Pre-treatment testing and safety measures that need to be taken with any monoclonal antibody is you need to make sure that patient does not have an active hepatitis B infection. You need to counsel the patient that they might have an anaphylactic reaction to the medication. The pre-treatment testing that needs to be done includes CBCs and hepatitis profiles. You need to make sure the patient has a good IgG level. You need to do a baseline scan on them, and you need to make sure all necessary vaccinations are given at least 4 weeks prior to the medication. The recommended monitoring schedule after the medications have been given include a CBC count as well as a metabolic panel. And you also, if available, need to look at the IgG levels every 6 months or so. Monitoring for malignancies becomes important at certain age groups as well, but the number of malignancies that are reported with them generally figure out that most of these patients had been on other medications prior to being shifted to the monoclonal antibodies, and therefore the blame goes there. So, but I guess with long-term follow-ups, at least for 7 years, patients who have been on ocrelizumab, it does not show a lot of significant number of malignancies. Other adverse effects aside from infusion, injection-related reactions, which is the most common side effect, are hypogammaglobulinemia. And relatively, the IgM levels tend to go down before the IgG and IgA. There's a lot of infections associated, especially respiratory tract infections and urinary tract infections. Opportunistic infections tend to happen as well, especially herpes, both zoster as well as simplex, and therefore the patient needs to be vaccinated against them before you start treatment. PML has been reported rarely, and hence Sadia said JC virus key screening is important. Some patients also develop immune-mediated colitis, and therefore, if a patient is complaining of abnormal bowel habits, that needs to be taken seriously in cases of patients being on monoclonal antibodies. Late onset neutropenia, I guess not always do we follow the lymphocyte count. Agar hum bahut closely dekhe, so we just look at the WBC count. We don't always look at the neutropenia, but I guess with patients with monoclonal antibodies being given regularly, you need to make sure that their fever, mucositis, or any other infection might actually be associated with neutropenia. So that needs to be taken into account. Also, some people prefer that if the patient has developed neutropenia, you can actually consider giving them CSF, and that might help. But if they have a reaction once, or if they develop neutropenia once, that does not mean they cannot be given another dose. Another thing, again, as I discussed, ocrelizumab in studies has been discussed for up to 7 years at least, and no long-term malignancies have been reported, but there have been the occasional cases of malignant melanomas and thyroid and breast malignancies. B-cell depletion occurs with CD20, as we all know, but CD19 is actually the cell that you target to see whether the depletion has occurred or not. And CD19, as I said, appears before the CD20. It actually appears on the progenitor B cells before the appearance of the CD20, and therefore you can actually trace it to see whether B cell depletion has occurred. And there's different definitions that needs to be followed, and if the availability is there, you should be checking CD19 as well. So what this graph shows is that ocrelizumab and obinutuzumab have a prolonged effect on the B cell repletion. And therefore, B cell repletion in cases of ocrelizumab actually starts around after 72 weeks, which is quite a long time. And therefore, you need to give the next dose before that. And again, ofatumumab has a very small time before which B cell repletion tends to occur. The first couple of presentations that we saw in the morning showed that we are considering that we are at the best possible phase to treat MS because we're seeing a lot of decrease in disability scores. However, there's different mechanism of actions of disease, and a lot of them target compartmentalized inflammation, which basically is when there's inflammation in the CNS which cannot be actually treated with the monoclonal antibodies considering their high molecular weight, and therefore there are additional drugs that are being investigated in MS. Dr. Burhan, I thought in the morning, I think, talked about CAR T cells as well, and CD19 जो NMO-ST में approved भी है, वो भी consider की जाएगी in the future for MS, but it has a different mechanism of action, and therefore currently we've been relying on these two drugs that he spoke about more so. So my take home would be that we are relying on anti-CD20 monoclonal antibodies first line therapies in MS currently. because they tend to decrease the clinical relapse, the MRI lesion activity, as well as delayed disability. However, a lot of patients do consider preference for IV or subcutaneous, and there's a lot of cost pair constraints as well. So financial considerations need to be taken into account. I'm hoping with the work of the government that's going on, support Balochistan mein, Punjab mein, hopefully things become easier for patients, and hopefully we do well with control of MS. Thank you. Any questions?